Good morning, everyone. Welcome to the second day of our first annual virtual conference for Children's Environmental Health Disparities in Africa. Today, we gather here not only as custodians of we gather here as custodians of the future, where every child thrive in a healthy and equitable environment. Our continent, which is rich in diversity and potential, faces unique environmental health challenges that are disproportionately affect our youngest and our most vulnerable. And that comes from polluted water sources to inadequate sanitation, encroaching threats of climate change, and the persistent problem of food insecurity. The environmental hurdles that we face they're complex and they're deeply intertwined with issues of equity and justice. This conference isn't just a gathering of minds, it's a call to action. As we engage in the various research projects to be presented here today, let's remember that the solutions we seek have to be as dynamic and as diverse as the challenges that we face. So it's also apt that today, the 18th of July, is Mandela Day, which honors the life and legacy of Nelson Mandela, the former president of South Africa and a global icon of peace and social justice. Today, you're volunteering more than 67 minutes of your time to attend this conference. I hope you're going to be here for longer than 67 minutes. And by so doing, you'll continue to foster his mission for a more just and equitable society, especially for our children. We hope that this conference will provide you with, if not answers, at least some ideas on how to use research to make a meaningful impact in your community and country. Together, let's strive to ensure that every child in Africa, regardless of their circumstances, can grow up in an environment that nurtures their potential and protects their rights. Let's be the change makers and the champions for a brighter, greener, and more equitable future. Apologies. There goes my phone. Okay, let's just carry on. What we're going to do is, for those of you that weren't here yesterday, we're going to do a quick recap of day one. So if you weren't here, then for those of you that were, you know how well it went yesterday. But basically, the whole purpose of this is we have students, and I'm sure you would have seen in the little booklet that we sent you as well. We've got students that are presenting their research, and they're either presenting research or proposals for research. And all of these are they deal with children and how to break the health disparities, the disparities that the children face. So what I've done is I just took a few words out of each project, just that felt important to me. And then from that, when we had interactions with the audience and with other researchers, they raised sort of gaps in research in this particular area. So that's what we're going to quickly have a look at. So our first student was Beatrice Mutai, and she spoke about cognitive stimulation amongst the mothers of infants in Nairobi. And we say here that the first year of life is critical. It's a critical time for child development. And the research question she asked was, did mothers engage in cognitive stimulation activities? And then stimulation, sorry, that's my spelling mistake. And then it was found that there were only a small portion of parents that did book reading or drawing or pointing things out. Oh, there's a little bird, there's a dog. They mainly sang songs or told stories. So, but one of the questions that was raised was, where can parents in that particular area get books? So a research gap was, can the proximity to libraries and playgrounds increase parent engagement in children's cognitive stimulation? The second student was Francesca Rollison, and she actually comes from Madagascar, and she has a project called Omina. Actually, it's a program where she's looking at breaking the cycle of emotional abuse for youth and children. And she actually told us a lot about this project, which is extremely interesting, a program. And she has some results on that. She uses, it's helping children to identify warning signs. They use social media. They have nearly 50,000 people on their social media platforms. So they're really, really reaching out. And as she stated, it's so important to be able to identify and recognize emotional abuse, because sometimes that is a precursor for physical violence and physical abuse. So one of the research gaps identified there was, are there improvements in emotional stability in children where programs, initiatives, or curriculums, including school curriculums, can include emotional training? We then had Napo Julius Molahleli, and he is from Lesotho. He's actually a student at UJ, and he was assessing blood lead levels and the risk factors in primary school children. And what he found, and this was quite scary because, you know, Lesotho, I'm from South Africa, and Lesotho is really on our doorstep, that there were unacceptable blood levels in nearly 50% of children. There's variable concentrations of lead in soil. So in some areas, in some samples that he took, it was very, very high. In others, it was negligible. The mother's education influences the child's blood lead level. So if there is a level of education, it tends to be that the child's blood lead levels are higher, as well as using paraffin for cooking, possibly, and also house renovations, where people had actually renovated their houses and used lots of decorative paint, which obviously we're looking at lead content in paint. And so the research gap there was, which heating or cooking devices increase blood lead levels in children? We then had the most amazing keynote address, and today you have two wonderful keynote speakers as well. And this was with Dr. Carity Wright, and she spoke about the impact of heat, especially heat as far as children are concerned, and how to eliminate the threats and so on. And obviously, you know, increased heat stress in children is as a result of the increased temperatures. And we're finding more and more heat waves. I think everybody knows that. I know at the moment we're in winter here in Africa, but well, in southern Africa, possibly north, it's very, very hot. But the main thing is that climate change is what has increased these temperatures. And there have been so many issues of renal distress in children. There's more hospitalizations with renal problems and so on as a result of heat waves. And she was suggesting that the schools should actually have policies regarding sport and outdoor play at increased temperatures. Do our schools do that? Are we looking after our children in this way? It can cause all sorts of other problems, but also your respiratory illnesses from increased allergens and so on. And then there are there's increased vectors like mosquitoes causing malaria, dengue fever, and so on, as a result of the extreme heat and floods and things of climate change. Food production can be impacted, and a big thing here, dehydration can affect breastfeeding, and that would be caused by extreme heat and higher temperatures. So, you know, if you just look at everything here, you can just see that there's just so much that needs to be done, and community education is important as well. You want to make sure the schools have access to clean drinking water, especially in these situations. So an interesting question that came up, and I think this is a very good research gap, is can cultural differences affect children's heat exposure? So do different cultures expose their children differently to heat? Do they swaddle them tighter? Do they carry them more? How do cultures make a difference here? Okay. The next session, because the day was divided into two sessions, the same as what yours will be, the session moderator was Dr. Nosiko Mnindi, and she's from the University of Zambia. She's also part of Break the Cycle Africa and a very integral part of it. And she just did a little talk on various case studies that have been conducted at the University of Zambia, dealing with children, dealing with lead exposure, indoor air quality as a result of cooking fuels and ventilation, and then interestingly, DDT usage in malaria areas and the impact on pregnant women and children under 5 years, as this can seriously affect neurological development. And a research gap there was, what are the levels of DDT in water in malaria areas, and how's that water utilized? In other words, are we spraying it on our crops? Are people drinking it? Are they bathing in it? You know, is that just another exposure to DDT? Our next student was Sunny Boy Njiko, and he spoke about schistosomiasis in the Nelspruit area of South Africa. And it was found that the age group most likely to contract bilharzia or schistosomiasis is aged between 10 and 14 years, quite often males, and more so in a rural setting. There needs to be a political will to draft schistosomiasis policies. There are really a large amount of children in those bilharzia catchment areas that do actually contract schistosomiasis. And he suggested mass drug administration for high-risk populations, as well as investigating snail elimination. The research gap areas, does recreational behavior influence the prevalence of schistosomiasis in children? Right, then we moved on to look at the student Goodson Shalabala, and he is actually Dr. Nisiko's student. He looked at cook stove technologies and child safety, and there's two things there. One is indoor air pollution, and another is actually the burns, so the safety of children, because they would be more prone to burns and burn safety. And this is still a proposal at the moment. So he is going to be looking at the perceptions and practices of the parents, of mothers and so on, in households regarding indoor air pollution and burn safety. And he looks at two things, two people. You're looking at whether it's a clean cooking or traditional cooking methods. So it's going to be a qualitative research study, and it's going to measure the indoor air quality. And the research gaps, there's what are the perceptions and practices of carers using different cook stove technologies in preschool centers, for example. He's looking at homes at the moment. And also, again, does culture affect cook technology perceptions and practices with regard to children? Our final keynote of the day was Dr. Onyemechi Nweki, and she is from the US Environmental Protection Agency. And she spoke about the equity lens and its implications for environmental health research and practice. And if you haven't heard of the equity lens, really go and have a look. It really is something quite eye-opening, I guess you could use for the name of the lens. But it's amazing that when you put an equity lens onto a policy, you can actually see how is that policy working? Is it actually helping the groups that it needs to help? Because basically it can pinpoint who's doing well and who isn't. Are marginalized groups being helped by these? Is there how does it affect them? How do the policies affect them? And policy practitioners should really engage with researchers to direct the research to answer the questions they're looking for while they're developing policies. So the research gap here is the equity lens applied to environmental health, spatial planning policies, any policies basically, to ensure the policies are positively improving the health of the underserved communities. So thank you for being here. And that is for actually taking part. And for those that were here yesterday, thank you for actually engaging with our researchers as well. Because really, as you can see, we've had quite a few valuable outcomes of it. So now, on behalf of myself, Samantha Langer, I just want to introduce Amanda Mbakwana, and she is from the Children's Centre of Environmental Health South Africa. She's going to be your moderator for today's program, and she will actually be presenting first on what the centre is all about and how it helps our children. Thank you. Over to you, Amanda.
Thank you very much, Samantha. Thank you very much. Colleagues, Dr. Samantha Lang, she's one of our board directors. She's an advisory on training and development, and she plays a very major role from the planning of this conference from the beginning of it until now, and we are grateful. And also I thank the team that is involved, our co-hosts and our co-sponsors. Thank you so much. Okay, as Samantha mentioned, I'm going to be the moderator for today for the first session of the morning under food insecurity and food safety. For now, I will share my screen just to give you a presentation on the work that we are doing and how is it linked to break the cycle. Thank you. Amina, let me try to share my screen. If I'm failing, you will assist.
Yes, absolutely.
I'll start with my presentation. My name is Amanda Mbikwana. I'm the Director of Center for Children's Environmental Health of South Africa. I'm also an EHP by training. I worked for local government. I worked for national health. Yesterday, I've noticed that most of my former colleagues are here. I think Samantha, maybe over 40% of our colleagues from South Africa attended our conference yesterday, and we appreciate your support. Thank you so much. Okay, I'm just going to give you a little background of what is children's environmental health all about. Since we know that in South Africa, it's under surface, disregarded. It's not much known. There's much work that is being done in research, but not necessarily in the communities. And most of our EHPs, they don't know much about it because they are not practicing it anyway, directly. And it's something that we didn't learn even in universities, not even in our curriculum. So, and also just to give you the background of what is happening currently in South Africa with regards to children's environmental health, and I'll take you through to our mission.
Amanda, you've gone on mute again.
Can you please move it for me? I'm struggling to move.
Yeah.
And your microphone keeps going on mute. You're still on mute.
Okay, and I'll take you through the project overview, our team, and break the cycle and conclusion. Okay, thank you so much. Children's environmental health is also known as environmental pediatrics. It's in the branch of pediatric medicine that study the influence of environment on children's health, development, and risk of disease. So it is based actually on the understanding that children have patterns of exposure and susceptibilities to environmental hazard as compared to adults. So the focus of research and practice in this children's environmental health is on discovery. It's ongoing. There's more research that has been done. Even yesterday, our presenters have presented a lot of informative research on breaking the cycle, focusing on children's environmental health. So there's diagnosis, treatment, prevention of diseases in children that are associated with harmful exposure in early life environments. So it is highly interdisciplinary, meaning it's related to more than one branch of knowledge. So it is concerned with chemical, nutritional environment, built environment, psychosocial, as well as interaction among those environment. It is concerned with the environmental exposure from pregnancy to conception, as well as with exposure in infancy, childhood, adolescent, and it traces the long-term consequences across lifespan of children's environmental exposure in early life. Furthermore, it's inherently translational. So we do research and we are able to translate the work that has been done into action. We take the recommendation and go to the communities and initiate projects and implement projects based on the research. So it is tightly linked to evidence-based advocacy for child health. Okay, so children's increased vulnerability to toxins as compared to adults. So children across all life stages from embryo to completion of adolescent are at a varying and increased health risk from hazardous environmental exposure as compared to adults for four key reasons. The first one is different exposure. So they get exposed through placenta, breastfeeding, as children, hand to mouth, they breathe faster, they have a higher skin surface, they spend more time on the ground. Different physiology, their development, they're still developing, they're still at the early stage of their life. Longer life expectancy, so they live longer, therefore they have longer period of exposure. Also the issue of politically powerless, they have limited voice, they cannot vote, so they rely on us as adults to make decisions for them so that we protect them from environmental hazardous environment risk and factors. So children are exposed to the same dose of environmental toxins or chemical have proportionately much greater exposure as compared to adults. Next slide, please. So what is the situation in South Africa? So most of the work that I've populated here, I took it from the research studies that were done. The first one was done by Professor N.G. Methy. She was looking at the development of children's environmental health in South Africa, the past and the gains and future opportunities. The other work was done by Hannah Andrea, rather from University of, I think it's Western Cape. So yeah, just to take, there's so much information, there's so much, just that I just took a little because of time, just to give you a background and understanding of what is happening in. So the research shows that South Africa is one of the most unequal societies in the world. Democracy has accelerated housing and basic services that benefit environmental health and South play and learn in hazardous environments, which is correlated with high rates of poverty. So it is estimated that 90 million children die each year, especially from poor countries, rather from preventable illnesses. So South Africa ranked at 30 among 42 countries that count for 90% of deaths. So according to World Health Organization, it estimated that in South Africa, 124 of every 100,000 deaths of children under 5 are linked to the environment. So globally, there is also a change in the pattern of childhood illness from communicable to non-communicable, many of which are caused by environmental factors and exposures. So this warrants a greater focus, including the establishment of acceptable levels of exposure for children and development of child-centered policies and regulations. So this slide is just to give you a profile of a population of our children in South Africa per provinces. So population estimate for the year 2015 indicated that there were around 5.9 million children under the age of 5 in South Africa. So there is an increase of 34% over the 4.4 million children counted in the census of 1996. So 43% of the children, they live in just two South African 9 provinces. So in Gauteng and KwaZulu-Natal, they home around 1.2 million of these children, which is 20% each. So 1.4 million, which is around 23% of South African young children. In Northern Cape, there's less than 2%. Limpopo, 12.4% of the Limpopo provincial population was under the age of 5 as compared to only 8.9% in Gauteng. To continue with the profile, I'll look at the unequal distribution of morbidity and mortality in South Africa. So, in South Africa, over the several decades of apartheid system, our government has engineered economic hardship and living condition of majority of Black people, so resulting in their children living in environment that are not healthy for their well-being, that are not safe for their well-being. So, but as we move through the years, there were improvement in terms of services and provision of housing and water. But nonetheless, just to give you a little bit of data on unequal distribution, morbidity and mortality in children. So children born in the Western Cape and Gauteng provinces, they have a greater chance of living in indwelling supplied with water and sanitation electricity. By contrast, when you look at Limpopo province, only 13% of dwellings have an indoor water supply, and 64% they use electricity for daily cooking, including KZN and Eastern Cape. So children living in settings of urban poverty may be subjected to high levels of air pollution from both indoor and outdoor sources. So the development of differences across these provinces, they may contribute to the large differences in life expectancy observed across provinces. Now look at housing and health in South Africa. As I've mentioned, that service deliveries improve and all that. But 13% of households in South Africa, they still live in informal settlement. Less than half, they have an indoor water supply or toilet. Around 17% use fuels other than electricity for daily cooking. These conditions, they contribute to preventable illnesses such as diarrhea and pneumonia, and they are still ranking among the top 5 causes of mortality in young South African children. And most of these deaths may be considered avoidable. Thank you. Children's environmental health in South Africa, it's a disregarded agenda. As I've mentioned before, improvements have been made. Housing programs have been introduced and implemented, but we are not there yet. We are not there yet. So there is much attention that is still needed to be directed to a range of additional environmental health risks facing children in their home and school environments, many of which have been relatively neglected. So studies that have been undertaken in certain areas indicate that around 20% of South African housing stock may be painted with lead-based paint. Elevated lead levels have also been found in paint applied to school buildings, playground equipment, and children's toys. Children experience multiple pesticide exposure scenarios in both urban and rural settings. South African studies have also found that babies with birth defects are more likely to be born to women exposed to garden and agricultural pesticides, as well as DDT indoor residual spraying. Okay, so now we look at the environmental exposures and risk factors impacting children's health. Most of our presenters, they've mentioned this from Dr. Ruben and to our presenters as well and our guest. Air pollution, inadequate water and sanitation, chemicals, radiation, community noise, occupational risk, agricultural pesticides, climate change, and built environments. So this is just to show you that the impact of environmental exposures on children's health by disease. By looking at the injuries, unintentional injuries, intentional injuries, non-communicable diseases, we look at cancer, mental behavior, and neurological disorder, and the environmental risks thereof. When you look at malnutrition, neonatal conditions, protein, energy, malnutrition, infections, and parasitic diseases. You look at respiratory infection that is caused by household air pollution, diarrhea, due to lack of access to drinking water. And malaria, inadequate management of stagnant water and poor housing. So this information, I've taken it from the work that was done by Professor Hannah Andrea. So this situation, this is a picture of what is happening in South Africa. Thank you. All right, so now I'm going to talk about our organization. And I just wanted to give you a background of what is children's environmental health, what is happening in South Africa, what is it that has been done in terms of research. So now I'm going to talk about our organization as a non-profit working to advocate for children's environmental health. Children's environmental, please go back to the, so thank you. The Center for Children's Environmental Health of South Africa is a non-profit organization that was established in 2020 during the time of COVID. So our organization caters for all children of South Africa, especially the disadvantaged between the ages of 1 to 18, to bring a positive change in their lives by improving their health. Our main objective is to reduce the exposure to a number of environmental risk factors where our children, where they live, learn, and play. So we work on scientific proven research data, and we actively work within communities, schools, early childhood development to increase the awareness and to promote scientific research in children's environmental health. You have to forgive me, guys, for the font. Okay, we also work through partnership with several interested parties, seek to change the current existing children's environmental health governance gap. We also aim to accelerate, amplify environmental health knowledge and practices that affect children, the children of South Africa, to reduce ill health caused by environmental factors among children, and to promote literature about children's environmental health. We also aim to the creation of children's database focus on various environmental health conditions capable of causing several harmful effects, and also investing in children's health through promoting awareness on health environments for children. What is our mission and our vision? Our mission is to provide a platform for strategic development of children's environmental health in South Africa. Our vision is to be a leading center of excellence in Southern African development community. So we are not, for now, it's because we are only starting, we are still new. We focus on the work that we do in our country, but as we grow, we are looking forward to spread our work to our neighboring countries and regions where fundamental children's environmental health and rights are prioritized, realized, and achieved. Our services. So we provide community education and awareness on children's environmental health. We offer support on training expertise to early childhood development on children's environmental health, including climate change. We promote research literature in children's environmental health. We promote the concept of knowledge of children's environmental health matters among environmental practitioners. I'm still going to take you through the programs that we have done on these services. We also initiate and collaborate with other organizations on knowledge exchange on children's environmental issues and public health challenges. Also providing incentive to interested parties in the promotion of children's environmental goals that are supporting our cause. We promote knowledge and awareness on social and environmental determinants of child health. What are our strategic priorities? So, most of our strategic priorities rather, we are already implementing them little by little. So we are doing small work there and there because we are still starting. So we promote knowledge and compliance by early childhood development centers and schools on children's environmental health. We advocate for children's environmental health to be included in the curriculum. This is it's a long-term thing that we want to achieve. We want to establish an effective communication platform to promote our organization with all identified stakeholders. This is already been done. We've developed a website with social media platforms. And we also have identified provincial coordinators to facilitate our work in all provinces. Identify coordinators in neighboring countries, Southern Africa, to disseminate information. Also fundraising to enable advocacy and promotion of our strategic objectives. As an NPO, we rely on funding and donations. a continuation of our strategic priorities to establish children's environmental centers or units in different communities within South African clinics or children's environmental hospitals. This one I'm going to just give you a little bit of brief information on it. Promote research in children's environmental health to inform policies, to promote the concept and knowledge of children's environmental health among health matters among environmental practitioners. Next slide, please. Oh, okay. So what is children's environmental centers? So this concept actually is adopted from a World Health Organization. So as an organization, we are in the process of partnering with Tshwane University of Technology. So Tshwane University of Technology, they have an organization within their department that is called Environmental Health Center, where they generate revenue to conduct research. So they approached us to say, we want to work with the organization to apply for funding in order to do research interventions programs. So, and one of the things that we want to do, we want to work from a center. We want to start piloting like a center. We can work in clinics in different communities, or we can have a mobile clinic where we do our work from there, where we collect data at the same time we are doing research, at the same time we are educating, at the same time we are doing the work, we are employing people, we have volunteers that are going to communities to do the work. So what is Children's Environmental Health Unit? It's a center that advances the ongoing training of healthcare providers, the ongoing education of the public and other sectors concerned about children's environmental health on the protection of children from environmental threats, and also the management of children with known or suspected exposure to environmental stressors, and the diagnosis, management, and treatment of children with illnesses that are derived from environmental stresses. So how are we going to do it? We'll be providing advice. So we'll be collaborating with, we'll be working with, let's say we are based in a clinic, let's say in Hillbrow or in Buipaton Clinic. So they will offer us an office there, operating in that office. Let's say in Buipaton, maybe they have an issue of sewage spillage, whereby they admit children into their clinic who are having the same symptoms of symptoms that are related to exposure, to contaminated water. So while we are based in there, because we'll be working more on the preventative measure and communicating the risk, so we'll be providing advice and referrals on cases involving either individuals or children or groups of children. Will be serving as a referral network for children with serious or more complex exposures. So we'll also having volunteering pediatricians or even volunteering nurses that will be coming there. And we're also planning training for them to be an ongoing training for the professionals. The indications for referring to a children's environmental health units could include uncertainty about the nature and extent of exposure that is involved, or uncertainty about environmental relationship with a particular health problem, or the need for assistance in risk communication, the need for specialized diagnosis or therapeutic intervention that will require a specialist, consideration of a new environmental related disease or disease of unknown origin. And also to educate the public about the impacts of environmental exposures on children's health, to alert the public to existing or potential risk and the appropriate responses, to develop educational materials adapted to a local needs and different media, to organize workshops, lectures, and other events on environmental topics, to provide guidance on laboratory services, to maintain standard data about all cases handled by our center, to alert agency officials or government officials, even EHPs, about existing or potential environmental health and steps to address them. Consult with government departments about situations to address the policies and the policies to adopt, to assist in the cases of natural or human-made disaster when children are affected. So colleagues, this is a new concept that we want to introduce. It's just a strategy for now. We haven't done it. So we are approaching different institutions also that are willing that will be willing to fund us. So we are still negotiating, we are still consulting, but it's something that must be done so that we operate from a center and we make an impact and our work becomes sustainable. And it also involves research intervention. And also we'll be creating employment. I mean, there are a lot of EHPs who are currently not working. So we'll also be creating employment, giving them stipends. You know, they'll come and do research, collect data. So it's a big thing that we are in the process of making it work. But we can't do it alone. We'll need other stakeholders. Even Dr. Rubin will also be part of it as we move along. So our values: to put our children first, ethical scientific research and partnership. Okay, our milestones since the inception of the organization from 2020. So 2021, we were doing webinars because it was the time of COVID between 2020 and 2022. So we're doing webinars for early childhood development centers on climate change, indoor air pollution, lead poisoning. We also managed to develop our site and participated in Children's Environmental Health Day. The Children's Environmental Health Day is commemorated in the United States of America. It's a national Children's Environmental Health Day. So we usually participate with them online. We just come up with a program and then we put it on social media. We support them. We like whatever that they are doing, to say we are with you. We are also supporting the work that you are doing. 2022, we came up with a program to train environmental practitioners. It was a CPD accredited program where we were charging the EHPs an amount of 200 Rand, and they were getting their CPDs. So it was a success. I think over 100 EHPs attended. We also had a youth program that was sponsored by a National Youth Development Agency, where we did a youth environmental leadership program in Soweto. We also participated in World Environmental Health Day with the National Department of Health. We were invited to come and present about our work so that environmental practitioners are aware, they know what we are doing. Also participated in Children's Environmental Health Day. We were also invited to COP17 to present on the impact of climate change on children. Dr. Rubin was also part of it. Children's Environmental Health Network was also there, and other organizations. 2023, we did collaborative community outreach programs. We were invited by different departments from local government, pick it up, environmental health. Whenever there's a program going on in different departments, we made sure that at least we become part of it so that we are able to reach communities. We started with Break the Cycle of Health Disparities with Dr. Rubin, just to have meetings and discuss what is it that we can do, how we can work together. We also collaborated with International Society of Children's Health and Environment. It's a program that looks at translating research to action. This year, we are here, Break the Cycle of Children's Environmental Disparities, a virtual conference. It's a success. It's the second day. A memorandum of understanding with the University of Technology, which is in the process. We were supposed to sign it actually yesterday, to finalize it yesterday and sign it, but it's something that we'll do next week. And also Children's Environmental Health Units. Yeah, just to take you through a project's overview. These are the high school students that we did youth environmental health leadership with them. Here we're doing a street cleaning in Soweto. Next slide. Okay, so this is the training that I mentioned earlier. And our line of speakers here, Dr. Joyce Sirendi, she presented on indoor air pollution and children's environmental health. And Professor Angela, and okay, on lead, and we had food hygiene and children's environmental health, tobacco, and our very own Dr. Samantha, she presented on environmental surveillance on children's environmental health. Okay. All right, this is the webinar that I mentioned for ECDs. This is the high school, just pictures, just to show you the pictures. Yeah, this is another one, the high school youth leadership program. And this is our community outreach. We also did a wheel with University of Johannesburg students. Yeah, this is our team. Yes, so just to say, addressing children's environmental health and breaking the cycle of health disparities within communities, it involves a multifaceted approach that integrates scientific research, policy, advocacy, community engagement, education, and equitable resource distribution. So we have started, this is what we are doing, a small work at a time, but we'll get there. All right. Conclusion to say safe and healthy and protective environment is the key to ensuring that all our children, they grow and develop normally healthy and effectively prevent and manage children's environmental health related illnesses. So we should work with a range of partners and stakeholders to foster a strong working relationship with our professional, social, and research institutions. Thank you. Thank you so much. Yeah, this is our contacts, and we have a website if you want to see more of the work that we are doing, or if you want to volunteer or contribute or donate. Thank you. Thank you so much. Our presenter is Amira Nyiko Mlangeni from University of Johannesburg. She's going to present about the knowledge, attitudes, and practices of food safety and hygiene among food handlers in primary and secondary school, Nkowa Seket in Limpopo.
A very good day to everyone. My name is Miss Amara Mlangeni, and I'm going to be doing my research presentation titled Knowledge, Attitude, and Practices of Food Safety and Hygiene Amongst Food Handlers in Primary and Secondary Schools in Nkowa Seket in the Limpopo province. And the study was supervised by Dr. Mbinani Flores Nika. Background. School feeding programs have been part of the South African educational system since 1994 as a South African constitutional right to education. The National School Nutrition Program pursued two distinct goals, which is food security, which seeks to improve health and nutrition of school-age children, and education, which seeks to improve attention, attendance, and performance. In 2004, the emphasis shifted towards education, from improving the nutritional status of learners to reducing hunger and alleviate the effect of malnutrition on their learning capacity and schools feeding. Hassel, Niker, and Syme believe that school feeding schemes were developed to form part of an intervention that will speak to addressing Sustainable Development Goals 2 and 3, which speaks to no hunger and good health and well-being, which target to decrease half of the proportion of people facing challenges worldwide due to hunger, and to ensure healthy lives and promote well-being for all at all ages. Food safety plays an integral role in ensuring the food consumed is hygienic and safe for consumption. Food hygiene is a measure taken to ensure food is safe from product to consumption. Globally, foodborne disease causes approximately 1 in 10 people to fall ill, with 420,000 deaths every year, 1/3 of them being children. Symptoms of food safety illnesses include stomach cramp, vomiting, nausea, and diarrhea. Worldwide, diarrhea disease caused 230,000 deaths annually, 96,000 of whom are children, and 1/3 of this death occurring in Africa. The knowledge and attitude and practices of food handlers play a crucial role in ensuring that the food is handled and prepared in a way that will not cause foodborne illnesses. Thus, it is important to study and understand the knowledge, attitude, and practices of food handlers to minimize cross-contamination and the occurrence of foodborne illnesses. The objective of the study was to determine the knowledge levels of food handlers about food safety and hygiene, to ascertain the attitude of food handlers towards food safety and hygiene, and to establish the practices of food handlers with food safety and hygiene. The hypothesis of the study was that food handlers in primary and secondary schools in the Ngwangwa sector of Limpopo province have a certain level of food safety and hygiene, knowledge, attitude, and procedures. Research methodology. The study was conducted within the confines of educational institution in Ngwangwa sector. As someone who was born and bred in Ngwangwa, I saw it as an opportunity to empower the community that I'm from, thus the location. The study employed a qualitative method, the use of questionnaires. 16 schools were randomly selected out of the 24 schools found within the Ngwangwa sector. 80 food handlers participated in the study, which accounted for 41.3% of the total population. The IBM SPSS was used for the analysis of data. This map below describes where Ngwangwa sector is found. It's found within Tzaneen in the Limpopo province of South Africa in Africa. Results. The chart below describes the food handlers' knowledge regarding food safety and hygiene. 96.3% of the food handlers agreed to cooking food in a clean environment. 77% of the food handlers agreed to washing their cutting board after each use, and 66.3% agreed to not handling food with abrasion or lesion. 55% agreed to knowing how to store food properly, and 57.5% agreed to not handling food while they're still sick. The next chart describes the food handlers' attitude towards food safety and hygiene. 73.8% of the food handlers disagreed that it is a waste of time to wash hands after every toilet or bathroom visit. 65% disagreed that they do not see the need to throw away food stuff that has reached its expiring date, while 50% agreed to not see the need to separate raw food and cooked food, and 52.5% disagreed to cleaning tables after food preparation is not important, and 41.3% disagreed that frequent hand washing during food preparation or handling is a waste of time. Lastly, the chart will describe the food handlers' practices regarding food safety and hygiene. 61.3% of the food handlers strongly disagreed that they wear gloves when touching food, and 58.8% agreed to covering food with a lid to prevent contamination, and 70% agreed to covering food while they were preparing and handling food, and 50% agreed to washing their fruits or vegetables before using them or cooking them, and 60% agreed to cleaning their working space. Discussion. In this study, most of the food handlers were knowledgeable about food safety, and the results that were found in this study were consistent with the findings of other studies, like the one conducted by Mapunga, which showed that food handlers have a proficient knowledge of food safety and hygiene. But at the same time, only 63.8% knew that they know what food poisoning is and its cause, which implies that as much as food handlers practice good hygiene, there's still a gap among food handlers who are required to be health educated. Education, training, and experience are crucial factors that can improve the knowledge of food handlers towards food safety and hygiene. Food handlers' attitude may influence the occurrence of foodborne infections. In this research study, a significant percentage of the participants have shown a positive attitude when it comes to food safety and hygiene of the food they handle. About 88.8% of the respondents disagreed and strongly disagreed that it is a waste of time to wash their hands, which indicates the importance of hand hygiene to the school's food handlers, and also demonstrates how much food handlers in the schools value food safety. The majority of the respondents, 82.6%, either disagreed or strongly disagreed with the statement, "I wear gloves when touching food," indicating a significant portion do not use gloves when handling food. This might be because of the lack of understanding of why they should wear gloves when handling food, or the lack of provision of PPE. Other literatures have shown that it is because of the lack of provision of PPE. That's why food handlers say that they don't wear gloves when touching food. It is well known that food handlers' attitude have a key role in applying knowledge and can significantly affect the individual's habits and practices. Food handlers who lack proper knowledge may adopt unhygienic practices, with 60% of the respondents agreeing to always cleaning their working space or when it looks dirty. A significant portion of the food handlers of 31.3% is neutral or disagree, indicating a room for improvement in maintaining a clean working space. Some of the poor hygiene practices of the food handlers may result from lack of awareness about food safety. How the project breaks the cycle. Well, how does my study breaks the cycle? It breaks the cycle in 3 ways: socially and economically. One of the recommendations in the study was that EHPs should conduct regular training on food hygiene and food safety to the food handlers, thus increasing the knowledge of food safety and hygiene. It also promotes economic growth. When less people are ill of foodborne illnesses, the money that was supposed to go to the healthcare systems can be used to promote and help to grow the economy of the country, thus also reducing the healthcare burdens and more productivity of learners in school. We all know that when you are sick, you need to stay and not go to school. But with less students being sick from foodborne illnesses, it will thus improve their attendance in school, improving their productivity. Environmental, less waste produced. With the food handlers aware of the concept of first in, first out, it will reduce expired foodstuffs in our shelves and thus reducing the amount of waste being thrown away. And we all know that when the food are thrown away, they reach our landfill sites, and with less food reaching our landfill site, it will also reduce the environmental impact of air pollution. Lastly, health outcomes. When food handlers are aware of what is food safety and hygiene, it will prevent foodborne illnesses, prevent of chronic diseases, gastrointestinal diseases, and prevent outbreaks. Strength and limitation, actionable outcomes. The recommendations in the study were the ones that can be easily implemented, thus creating an actionable outcome of the study. Diverse cohort, the participants were of different age groups, thus creating a diverse cohort of age. Replication, the results of the study were consistent with other results of other studies conducted in Africa. Limitation, considering the fact that I only had a year to complete my research, there was inadequate assessment during data collection, also affecting the sample size. I didn't manage to reach the targeted sample size that I had. And then social desirability bias. The questionnaires were self-respond, which can tend to create a social desirable bias and not showing the true reflection of what's happening daily on day-to-day basis. In conclusion, we can conclude that training does not equate to the knowledge and attitude and practices of food handlers towards food safety and hygiene. Thus, regular inspection by environmental health practitioners, EHPs, to check and monitor compliance and put more emphasis on food safety and food hygiene practices are necessary. The South African Foodstuffs, Cosmetic and Disinfectant Act number 54 of 1972 regulates food safety and hygiene and is an applicable legislation for storage of raw food and cooked food. This legislation can be used by our EHPs as to ensure compliance and when doing our monitor checkups. I'd like to take this time and acknowledge my fellow colleagues that were with me in completing this research and thank my supervisor, Dr. Sinikani, and also thank the Mopani West District of Limpopo Province to give us permission to conduct our research there. And lastly, I want to thank the BTC community for granting me this opportunity to come and speak about my study and educate people about my findings. And this shows my references. Thank you.
Thank you so much, Amira. Any question, any comment, colleagues? You can type your questions on the chat.
All
right.
What lessons would you share with us as the audience as to what you discovered and would recommend personally?
I can say that as much as food handlers are well versed in food hygiene and safety, however, there is still a significant gap of food safety that can pose a risk. So it is up to us as EHPs to take it upon our hands to go and ensure compliance in our schools and ensure that they know what is food safety and practice it on day-to-day basis. And another thing that I'd like to share is that I wish that in the near future, someone can conduct a longitudinal study, which is observational, where the researcher can go and see what happens there in day-to-day basis, instead of like going there and asking questions, which can also cause social desirability bias and not getting a true reflection.
Very good. Thank you so much. Amanda, over to you.
Okay. Thank you, Dr. Ruben. Okay. Our next presenter, Hayley Kimberlyn Langley. I'm just going to introduce her. She's currently pursuing her master's degree in environmental health at the Cape Peninsula University of Technology, Africa. Born and raised in Vredenburg, South Africa, Hayley developed an early curiosity when she completed in the ESCOM Expo Science Fair, where she purified sewage water in a domestic manner for those with no access to clean drinking water. For the past 2 years, she has been employed at the Cape Winelands District Municipality as an environmental practitioner. Over to you, Hayley.
I'm Hayley Langley. I'm a master's in environmental health student at the Cape Peninsula University of Technology under the supervision of Prof. Human and Prof. Odendaal. And the title of my project is The Influence of Training on Food Handlers' Hygiene Knowledge and Practices in the National School Nutrition Program of a Cape Winelands Sub-District Municipality within the Western Cape, South Africa. Okay, so some background of my study. The South African government and other stakeholders provide healthy meals for learners because they believe it encourages learning and enhances their health. Because they believe it encourages learning and enhances their health and development. The National School Nutrition Program was established in 1994 and provides meals for plus minus 9 million learners daily. Estimates done on the global burden of disease indicated that 1 in 10 people fall ill every year due to contaminated food. This results in 420,000 deaths per year, and children under the age of 5 are more vulnerable, and this causes 125,000 deaths per year reported for this age group alone. It was evident that the region of Africa and Southeast Asia has the highest mortality burden when it comes to contaminated food. The World Health Organization revealed that 70% of all diarrhea diseases in African children are due to complementary food that was contaminated. In South Africa, foodborne illnesses are not properly reported, even though it is so common. Here are some examples of food poisoning incidents in South African schools. I'm only going to highlight a few. In 2014, 2 schools in the local sub-district was examined for food poisoning after learners ate at the school's feeding scheme. In 2016, 90 learners experienced stomach cramps and diarrhea after eating at the school's feeding scheme. After samples were taken, it was the bacteria Clostridium perfringens were found. At the secondary school in Bloemhof, one death and several learners were hospitalized. After investigation done by the environmental health practitioner, it was found that the storeroom was infested with rats and they lacked equipment to prepare safe food. In 2020, 250 learners were rushed to the hospital due to a suspected food poisoning at the Eastern Cape High School. This was due to improper handling and processing of tinned fish. In 2023, the Department of Health confirmed a foodborne disease outbreak at 2 neighboring schools, where 120 learners was affected between the age of 8 years and 15 years old. As mentioned, this is only a few examples. There are many more that we know of and probably not even reported. So the study area for my project. One sub-district within the Cape Winelands district that falls within the Western Cape province of South Africa was selected. The sub-district covers 4,518 square kilometers and is home to 100 and plus minus 120,000 residents and 31,000 households. The sub-district also consists out of 5 towns that has 39 primary schools who all provides food for their learners. Each of the 5 towns had 2 schools purposefully selected, one being a town school and one being a rural school. The aim of the study is to determine whether a food hygiene training intervention at schools offering the National School Nutrition Program will improve food handlers' knowledge and practices will improve the knowledge and practices of the food handlers. The hypothesis is that implementing food hygiene training in the National School Nutrition Program will lead to a significant improvement in food handlers' hygiene knowledge and practices. The methods used for the study. The sample population, as I mentioned, 10 schools in the Cape Winelands sub-district was purposefully selected, 5 town schools and 5 rural schools. The sample population consisted out of 30 food handlers. Permission was obtained from the Department of Basic Education and the Cape Winelands District Municipality. So the first step was to do the pre-training visit. 1 school was visited per day around the same time, and this was while the food handlers were preparing lunch. While the food handlers were busy preparing lunch, I made some observations by using an observation checklist. Whilst the lunch was served, or after the lunch was served, the food handlers were requested to complete a questionnaire that was in the form of a Likert scale. And then once all the schools received their pre-training visit, training was provided by myself based on the 5 keys to safer food and the South African regulation, Regulation 638 of 2018, the regulation governing general hygiene requirements for food premises, transport of food, and related matters. So the training methodology integrated a visual demonstration to effectively communicate the 5 keys to safer food and Regulation 638 of 2018. In addition to the visual presentation, a 4-minute educational video based on the 5 keys to safer food that was developed by the World Health Organization was screened. And complementing these visual tools, a structured PowerPoint presentation consisting of 38 slides speaking to the duties of the food handlers was presented. The entire training session was concluded within 1 hour. Three months after the training was received, the post-training visit occurred. The post-training visit was done in the same manner as the pre-training visit, but the only difference was that the questionnaires was now in the form of a multiple choice question. For data analysis, data was captured and is currently analyzed by a biostatistician of the Cape Peninsula University of Technology. By using the statistical package for social sciences, the SPSS software program. The expected results of my study. As mentioned, my results are still being analyzed, so I do not have results to present as yet, but I can say all 10 schools participated. I received a total of 30 pre-training and post-training questionnaires that was completed. 7 of the food handlers came from rural schools, and 23 of the food handlers came from town schools. It is expected that my results will give a clear understanding on what the baseline of the food handlers' hygiene knowledge and practices was before the training was received. And after training, it is expected that the results will show that the food handlers' hygiene knowledge and practices had improved due to the training they received. So, how does my study break the cycle? Training food handlers on food hygiene knowledge and practices is a crucial step towards breaking the cycle on children's health disparities in several ways. The first aspect where we break the cycle is the social and economic. Firstly, improve food safety. Proper training ensures that food handlers understand the principles of food safety, including personal hygiene, proper storage, cooking temperatures, and preventing cross-contamination. Secondly, increase school attendance. Foodborne illnesses can lead to absenteeism and poor academic performance. By preventing foodborne illnesses, children are more likely to attend schools and actively participate in learning. Access to safe food. Many countries lack access to safe and nutritious food. By providing training, there is a commitment to ensure that all children, regardless their socioeconomic background, have access to safe and hygienically prepared food. Lastly, community empowerment. Training food handlers does not only benefit the learners, but it extends to their families and communities. Food handlers can become advocates for food safety in their communities by distributing knowledge that can improve the overall public health. The second aspect where my study breaks the cycle is the health risk factor. By providing safe food for learners, the risk of foodborne illnesses decreases and in return, leading to a healthier child. In essence, by prioritizing food hygiene training for food handlers in the National School Nutrition Program, this can play a vital role in breaking the cycle by promoting access to safe food and fostering a healthier and more prosperous community. The strengths of my study. A pilot study was done to ensure validity and reliability. All participants completed an informed consent form, and the identity of all schools and participants were protected. Limitations of my study was time constraints. Due to distances I had to travel between schools, I had to find a suitable time that will benefit myself, my study, the food handlers, and the schools. Suggestions for the future. Future studies can possibly focus on hygiene attributes of the food handlers. For example, now they have the knowledge, maybe look into why they do not practice it. Training material developed for the study can be rolled out to environmental health practitioners to train food handlers at different schools. And in conclusion, the study will give valuable insight into food handlers' hygiene knowledge and practices to assist in providing safe food for learners, and in return, breaking the cycle of foodborne outbreaks in our schools. Acknowledgements. I would like to express my heartfelt gratitude to Prof. Human and Prof. Urendal for their invaluable mentorship throughout my project. Their guidance, expertise, and unwavering support have been instrumental in shaping my research journey. I'm also deeply thankful to the Breaking the Cycle organization for granting me the opportunity to participate in this conference. And lastly, I extend my sincere appreciation to my family and friends for their endless encouragement and support. Thank you. Any questions?
Thank you so much, Hayley. Thank you so much. Colleagues, do you have any questions for Hayley? She's still waiting for her results. Samantha, yes?
Thanks. Can I maybe come in? I just want to, mine is more a comment than a question, which is I didn't put it into the chat. Because of course we're going to see now with the following student as well, that is, they're looking at a similar thing, food handlers with in childcare and so on. And I think as EHPs, we can see that there is a serious lack of sort of a disconnect between what the food handlers' knowledge is and what their practices are, or even how much they're retaining the knowledge and how much of the knowledge they understand. So I think that's why it's important that we see all these research projects, because they are, it just shows the importance of it, that there are so many people investigating it from various angles to see how we can best help these food handlers to provide safe food for the children, especially in our country where we do have the National Nutrition Program. So I just want to say thank you to Hayley for also going down this road. And yes, we're looking forward to seeing the results and reading about the results when you get them. So good luck with that. Thank you.
Thank you.
Thank you, Samantha. Dr. Nusiku?
Thank you, Amanda, and thank you, Hayley, for a very informative presentation, and wishing you all the best as you continue with your study. My question is, from your presentation and maybe the one before yours, what is the role of policymakers, of regulators in food safety? In this case, both of you, I think, are looking at school feeding programs. What is the kind of policy or regulatory environment around that? Is it under the local municipalities? Is it the educational sector, school management themselves? Who's there to enforce and make sure that these regulations, or if there are any regulations that they're actually being followed? Thank you.
Okay, thank you for the question. So the environmental health practitioners that works under the local government, the district municipalities of South Africa, they are responsible to monitor these schools. They do it according to the regulation I just mentioned, Regulation 68 of 2018. And by law, environmental health practitioners are supposed to visit these premises twice a year. So yeah, they are responsible to regulate these premises.
Okay, and the school authorities?
Okay, so for that I know of, most schools, the Department of Education, they just provide the food and the building, but then the food handlers are on their own. Or that's what I know. I'm not sure if it's like that across the country.
On my side, when collecting data, they're like a representative, so someone who overlooks the feeding scheme and like is there in day-to-day to check if they are practicing food safety. But then the person is also a teacher, so they don't have enough knowledge on really what is food safety. So they just allocate a teacher to be in charge of the feeding scheme.
Yeah, and mostly that teacher is just responsible to order the food products that we.
You know, the issue of food safety, there's a gap, because we do inspections, we offer training, but it seems like the attitudes of the food handlers don't change. And as you are saying, Amira, they're using the teachers to supervise the food handlers, and really the teachers, they do have other duties. I remember I think it was around 2007, TUT used to get some of the students who just graduated. There was a program actually where they were sending newly graduated students to schools to do inspections, to be there at the schools, to be stationed there at the school, to do inspection on what do you call food feeding scheme at schools, and also to offer training. And I also think maybe, I mean, doing inspections twice a year to a school and training them, and you come back, you expect to see a change. These people, they go back again to the same attitude. So I think, as Dr. Samantha mentioned, there's a gap. We need to improve. Something must be done with the regulation, the policy. Something must be done, really. because our children, they keep on getting sick, they keep on dying. We are doing research, we do inspection, but same thing, it keeps on coming back again. Yeah, I think really there's a gap here. Okay, colleagues, it's a body break. 11:25, we'll come back at 11:35. Thank you so much. Welcome back, colleagues, from the body break. We are welcoming our third speaker. Her mentor is Dr. Samantha Lang. She's going to introduce her. Her name is Merisha Babulang. Over
Morning
to you,
again.
Dr. Lang.
Thank you. Morning again, everybody. I just want to welcome Merisha Babulal. It's a huge pleasure to introduce her. She's a chief EHP with the South African Military Service. She's actually in the Defence Force. She's currently pursuing her master's degree in public health, and I'm supervising her. And she's got 20 years experience as an EHP and as a soldier during her deployment in the United Nations peacekeeping mission in the Democratic Republic of Congo. She gained a deeper understanding of public health challenges. Take us away, Merisha. Show us what you've got.
Thank you, Samantha. Okay, I hope you can all see.
Yes, we
Can
can.
you see? Oh, okay.
Yes.
All right. So
Thank you.
as mentioned, I'm Merisha Babulal, and Dr. Samantha Lange is my supervisor, and my co-supervisor is Ms. Renee van Wyk from the academic institution, the University of Johannesburg. So the title of my study is determining the level of food safety practices at early childhood development centers within the eThekwini communities. So with regards to the background of my study, an early childhood development center is a facility that provides care to children under the age of 6 years. Now, in some countries, an ECD center may commonly be referred to as creches, preschools, or daycare centers. So early childhood care and proper nutrition play a significant role in a child's development, taking into consideration that they spend a considerable amount of time at these creches every day. According to the General Household Survey that was conducted in 2022 by the Statistics South Africa, there was a significant increase in the number of registered ECD centers in the country compared to previous surveys conducted in 2015. So the sudden increase in the number of ECD centers in the country, and both in the formal and informal sectors, provides a growing concern for food safety measures. And at the same time, and as you heard from the previous speaker, there's been numerous food safety outbreaks or suspected food safety outbreaks in the country. In the Eastern Cape province, in 2 schools in 2023, 2 schools experienced suspected food poisoning outbreaks. And in 2024, 41 preschool children aged between 3 and 5 years were hospitalized at the Chris Hani Hospital. So poor food handling practices may result in potential foodborne illnesses and even death. Good food hygiene practices by food handlers, such as hand washing, temperature control, and good food storage practices are imperative in preventing foodborne illnesses. Thus, food handler knowledge, behavior, and practices play an integral role in food safety. So the hypothesis for my study is that there is a significant variation in the level of food safety practices among registered early childhood development centers within the eThekwini municipality. These ECD centers may be managed by people who have inadequate knowledge of food safety or by inexperienced food handlers. The non-compliance of food handlers to good food safety practices and behaviors places children at risk of foodborne illnesses and diseases. So the methods for my study, it is a cross-sectional quantitative study. The sample population of food handlers at registered ECD centers in eThekwini municipality in the province of KwaZulu-Natal. The sampling method is convenience sampling, and this allowed for the selection of participants based on their availability and willingness to participate. The estimated sample size was 160 food handlers derived from 56 ECD centers. And the data collection tool is the WHO 5 Keys questionnaire. So the 5 Keys assesses the behavior, the practice, and the attitude of food handlers. And just to go more detail, Key 1 focuses on keeping clean. Key 2 on separate raw and cooked foods. Key 3, cook food thoroughly. Key 4, keep foods at safe temperatures. And Key 5, use safe water and raw materials. So this study, this map indicates the study site. It shows the different suburbs that make up the eThekwini municipality. So just to give you a clearer picture of where eThekwini municipality is within the province of KwaZulu-Natal on the east coast of South Africa. eThekwini can also be described as the economic hub of the province and also or previously well known as Durban. So this study, we just completed the data collection, and during our collection period, we experienced numerous challenges in terms of traveling to the outer areas of the municipality. We also encountered communication difficulties as the database that we were using had incorrect telephone details and addresses. Also, some of the ECD centers were either closed, no longer operating, and unfortunately, our data collection started during the school holidays. So many of the creches, due to absenteeism, they decided to close the facility for the holidays as well. So in terms of data analysis, okay, so capturing is currently in progress. For the data analysis, we will be using the IBM Statistical Package for Social Science version 29. Various aspects of food safety knowledge among ECD food handlers can be assessed by using categorical and continuous data. To investigate the association between these characteristics and food safety knowledge, descriptive statistics and regression analysis will be performed. So in terms of how this project breaks the cycle, we will be focusing on the social, economic, as well as the health outcomes. In terms of social and economic, we did encounter many ECD centers that were under-resourced due to lack of funding. Access to water was a challenge in some areas, very poor infrastructure. So all these contribute to poor food safety practices. And then in terms of the health outcomes, improved food safety practices can lead to better health outcomes for children and also reducing the disparities in health status between different communities. So by improving food safety practices at ECDs, the study can contribute to breaking the cycle of social, economic, and health outcomes. Some children who may attend the ECDs may come from disadvantaged backgrounds, and ensuring their health and well-being is a crucial step in breaking the cycle of poverty. So by ensuring and providing safe food at these centers, children are less likely to suffer from foodborne illnesses, which can lead to absence from school and also hinder their educational development. So healthy children are more likely to attend and excel in school and increases their chances of obtaining higher education. Foodborne illnesses can also put a strain on the healthcare costs. So by ensuring proper food safety practices at ECDs, the study can help reduce the incidence of foodborne illnesses, leading to lower healthcare expenses for the country or community. So in terms of the strengths and limitations, strengths, The study is relevant because it addresses the crucial issue of food safety in vulnerable populations. We focused on registered ECDs. Thus, it's a more controlled investigation as these facilities adhere to some sort of minimum legislative standards. And we are utilizing a standardized, validated WHO questionnaire, the 5 keys. In terms of limitations, we did encounter ECD resistance and lack of cooperation, and this is purely because of the stigma, fear, and anxiety associated with an environmental health practitioner visiting a facility to close it down. It was limited to only registered ECD centers, limited availability of participants, and then also resource constraints. Limited time could affect the sample size or depth of data collection. In terms of suggestions for future research, we'd like to investigate the factors influencing the variation in food safety practices, whether it's staff training, funding, infrastructure, and resources available to the ECD centers. We'd like to evaluate the effectiveness of training programs in improving food safety practices, and also evaluate the effectiveness of regulatory bodies in ensuring food safety. So in terms of that, the legal framework governing early childhood development centers varies nationally and internationally. And in South Africa, we have various levels of government that have managed the early childhood development centers over the years. In 2021, the Department of Basic Education took over governance of these facilities from the Department of Social Development. However, the municipal environmental health practitioners are in charge of monitoring and evaluating such centers to ensure compliance with the environmental health norms and standards, 2015, as well as with the regulations governing the general hygiene premises. In conclusion, the study is expected to give information about the current food safety practices, identify barriers or challenges affecting food handler compliance, and make suggestions for improving food safety measures. The study's results will help identify any areas where ECD centers will need additional food safety training and can promote a change in policy to improve food safety practices at ECD centers, thereby improving children's health and well-being. I'd like to acknowledge the University of Johannesburg, the Faculty of Health Sciences, Environmental Health, my supervisors, Dr. Samantha Lange, and co-supervisor, Ms. Renee van Wyk, the eThekwini Municipality Environmental Health Monitoring and Evaluation, environmental managers, Mr. Lucky Mkize and Mr. Karabo Modikane, and the Department of Education in KZN for granting me permission to visit the facilities under their area of jurisdiction. These are the references and questions.
Thank you so much, Marisha, for an important study, and it is really necessary because you are looking at the environment where you are dealing with children who are under 5 years old. And according to the studies, World Health Organization, UNICEF, there's a high mortality there in terms of food safety, environmental hazards, and injuries and all that. It's commendable. Thank you so much. Colleagues, any question or comment in the chat? You can type.
I just, hey, Leslie Rubin here. I just want to thank all the speakers so far, and I know we've got one more, for focusing on such a critical aspect of child health and nutrition, but also on the food safety issues. As you recall, our keynote speaker yesterday, Carrie Wright, had commented on aspects of hydration and needing to drink a lot of fluids during the hot summer months. But also she commented on one hand basin there for all children to wash their hands in the same basin with the same water. So that's another risk. So I think the work you're doing in raising awareness is very significant, and your relationships with the schools, the early development centers, the food handlers, and all levels are really commendable. So I urge you to continue your good work. Thank you.
Thank you, Dr. Ruben. I will introduce our last speaker for the morning session before our keynote address. Let's welcome Amarachi Pascaline Onyena. Dr. Amarachi Pascaline Onyena is a dedicated environmental scientist with a PhD in marine biology. Her research focuses on the ecological impacts of pollutants, particularly hydrocarbon and microplastics, on aquatic systems. Dr. Onyena has a strong publication record in top-tier journals and has presented her findings at international conferences. She is skilled in ecotoxicology, environmental risk assessment, and the application of ecosystem models. She is passionate about mentoring and has guided numerous undergraduate and graduate students in their research pursuits. Dr. Onyena is committed to advancing environmental science and fostering sustainable solutions. You are welcome, Dr. Onyena. You may proceed.
Okay, thank you very much. Like I've been introduced already, my name is Amarachi. So I'm presenting today lactational exposure of human infants to metalloids, a comparison of sub-Saharan Africa and Mediterranean Europe. Imagine this, every drop of breast milk valued for its benefits to infants globally can also carry unexpected risk health. Yet, the presence of these metals and metalloids in breast milk have profound impact on infant health, and it's often overlooked. So I'll be guided by this outline to explain my research. Breast milk is universally recognized as nature's perfect food, offering a balanced mix of nutrients that supports rapid growth and immune system development in babies. It provides crucial antibodies that shield infants from infections and promotes long-term health while fostering cognitive and emotional development, crucial for their future. Yet, amidst these benefits lie hidden dangers. Metals and metalloids originating from sources like industrial activities, volcanic eruptions, wastewater, agricultural activities, mining, and other environmental pollution find their way into breast milk. In regions with limited waste management and regulatory framework, exists some oversights about breast milk contamination. And it's very evident in sub-Saharan Africa, where these contaminants pose significant risk to infant health. Conversely, in urban centers of Mediterranean Europe, diverse pollution sources shape the context of breast milk contamination differently. Studies reveal elevated levels of metals like zinc, arsenic, lead, mercury in breast milk from women exposed to industrial and mining activities. This research is a systematic review that we searched PubMed Central, Cochrane's Corpus, and we searched for relevant publications for this review from these mentioned databases from inception up to December 23. Certain keywords were used. Example, breastfeeding, as you can see from the slide, breastfeeding, trace metals, for the different metals, exclusive feeding, and other keywords were used to get our articles. Now, from this literature review, we were able to see, we have a systematic review of 570 studies, which was later narrowed down to 43 comprehensive analysis across sub-Saharan Africa and Mediterranean Europe. The eligibility of the results that made it narrow down to 43 were that we recruited a population of breastfeeding mothers and infants of young children from 0 to 2 years, and only articles that are measuring concentrations of heavy metals in the breast milk of lactating mothers were used, and only studies from sub-Saharan Africa and Mediterranean Europe was also used. Now, the articles were also that was found for this research were mostly cross-sectional. We used cross-sectional methods with a single case study from Nigeria. And then also different analytical methods. Out of these 43 studies, 15 studies used atomic absorption centrifugometry to analyze the heavy metals, while some use ICP-MES, others use other apparatus to analyze their heavy metals. The study shows that in sub-Saharan Africa, included 26 studies, the studies that were gotten from sub-Sahara, with Nigeria leading in numbers, while other countries like South Africa, Zambia, Namibia, they only have a few articles regarding lactational exposure of metals and metalloids. Similarly, in Mediterranean Europe, only 17 studies were gotten according to our eligibility criteria, and Spain was also having higher articles regarding that. All other ones were really France, and other ones had limited number of publications based on what we are looking for. So this metal concentration varied widely with in sub-Saharan Africa, cadmium levels range from 0.013 microgram per liter in South Africa to 29 microgram per liter in Nigeria, all surpassing the WHO limit. Lead concentrations range from 0.13 microgram per liter in South Africa up to 38 microgram per liter in Nigeria, also exceeding WHO guidelines. In arsenic levels range from 0.17 microgram per liter in South Africa to 26.70 microgram in Ghana. Mercury concentration range similarly, with some studies in Europe exceeding WHO limits. Trace elements like the selenium shows significant variability, with levels ranging from 3.4 microgram per liter in Ethiopia to 171.65 microgram per liter in Ghana, and from 5.3 microgram per liter to 44.5 microgram per liter in Spain. This study actually says that in sub-Saharan Africa, studies highlighted alarming levels of metals in cadmium, lead, arsenic, and mercury exceeding WHO guidelines. But the studies also showed that Mediterranean Europe, due to proximity to industrial hubs, significantly influenced metal exposure, therefore highlighting the need for stringent environmental controls. So the study altogether also analyzed for their health implications and found out that most of these studies say that there are possibility of profound implications for infant health, including prolonged exposure to impairing neurodevelopment, compromise of their immune functions, and also hinder their infant growth. From these studies, so many factors were also found out to be contributing to the metalloid, and for that of these factors originated from the combination of socioeconomic and environmental influences. In sub-Saharan Africa, high metal exposure are primarily linked to extensive mining activities, including extraction and smelting of minerals and electronic waste. These processes contribute significantly to environmental contamination, compounded by inadequate occupational safety measures and poor nutrition. Also, contaminated food and water further increase the susceptibility to metal toxicity in the region. Also, in Mediterranean Europe, the proximity to industrial sources like the ferromanganese alloy plants and intensive traffic patterns plays a pivotal role in the metal exposure. Another point that was also listed is the dietary habits, which such as adherence to the Mediterranean diet also influence the exposure levels. Higher adherence to diet is associated with the increased exposure to non-toxic metals like the arsenobetaine, while exposure to toxic metals like copper was reduced. Another contributions were the industrialization and agricultural practices in both regions. In Sub-Saharan Africa, poor management of industrial effluent and contamination of agricultural soils contributed significantly to the elevated metal concentration. Similarly, rapid urbanization and industrial growth led to the soil contamination with heavy metals, posing health risks to residents. In Mediterranean Europe, industrial activities in steel-making areas are major contributors to heavy metal contamination. Also, there are cultural life and lifestyle factors. Some persons, some of these studies also show that some had some cultural beliefs that maybe staying in one particular place during pregnancy, and that could also initiated in their heavy metal exposure. Others include influence on bioaccumulation due to higher residents in industrial areas. Now, from all these studies, the determinants of metalloids in the breast milk were found out to be, according to geographical location, their dietary habits, environmental exposure, then the analytical methods. Due to different methods, different of these articles had different analytical methods and different standards they used to carry out the heavy metals. So other ones were their behavioral, maternal smoking, and the use of well water, alcohol consumption, and some other socio-demographic factors. So efforts to mitigate lactational exposure to metalloids in both regions emphasize identifying high-risk populations, targeting exposure sources, and implementing primary prevention measures. Strategies include improving occupational and environmental safety standards, reducing environmental contamination through engineering controls, and promoting public awareness and education on dietary and lifestyle practices that influence exposure levels. Another one is community engagement and policy implementation for effective implementation of these strategies, ensuring that sustainable reduction of metalloid exposure and protecting public health in these two regions. Now, there have been successful programs, and of course, there have been challenges also in using them. So this, for example, is the Baby-Friendly Hospital Initiative, the BFHI, and the Women, Infants, and Children, WIC programs. They have made significant moves in promoting breastfeeding. For example, this BFHI is a global program launched by the WHO and the UNICEF, which encourages hospitals and birthing centers to provide optimal care for infant feeding and mother and baby bonding. This initiative has increased breastfeeding rates, improved their maternal satisfaction, and enhanced health outcomes for both mother and the infant. While the WIC program in the United States supports low-income pregnant women, new mothers, and young children by providing supplemental nutrition, education, and breastfeeding promotion. It also offered access to healthy foods, peer counseling, and community support. However, despite these successes, several challenges hinder the implementation, which include inconsistent national policy support, inadequate training of healthcare professionals, and limited funding and resources that can undermine the program effectiveness. Additionally, indigenous communities often experience lower breastfeeding rates due to cultural barriers and limited healthcare access and socioeconomic factors. Now, from these results, from these 43 studies that were used for this systematic review, there were key research areas. It was found out that there's a need to expand research beyond sub-Saharan Africa and Mediterranean Europe to include other regions with diverse industrial and environmental contexts. And also, the results that that was gotten for this study was mostly cross-sectional studies. So there's a need to conduct longitudinal studies in the sense that you measure them over time, not just 1 point measurement. Longitudinal studies to track how metal concentrations in breast milk change over time and assess their cumulative exposure effects on infants. There's also a need to investigate how regional dietary habits impact metals and metalloids in breast milk to develop targeted dietary recommendations. Then there are further research on specific health impacts on metal exposure through breast milk, focusing on the neurodevelopmental and immune system effects in infants is needed. Also, the gap also is that there is a need to standardize analytical methods for measuring metal concentration in breast milk to enhance comparability across studies. Then there's also need to explore broader environmental contributors to metal contamination in breast milk beyond industrial sources. I mean, you can also check the impact of climate change and agricultural practices to see if there's any way this climate change also increases lactational exposure to metals. Then there's also a need to evaluate community-based interventions, maybe through questionnaires, through interviews, and develop policy measures that aid at reducing metal exposure through breast milk in order to inform effective public health. To break the cycle of children health disparities, so this study have been able to have a systematic review of studies from inception. You see that it's just only a few studies that was able to, analyze the areas of interest. Then it has also been able to identify contaminants and exposure source, and also the need for policy and community engagement. In conclusion, while breast milk remains a vital for infant nutrition, awareness of potential contaminants is vital. This study highlights the urgent need for targeted intervention and policy reforms to mitigate risk and protect children. Together, we can strive for a future where every child can benefit safely from nature's gift of breast milk. I would like to acknowledge the BTC Africa and also my mentor, Professor Rich Orisakwe, and also other collaborators too, who also were also involved in data collection from different databases. Thank you.
Thank you so much, Dr. Onyena, for such an informative presentation. Colleagues, do you have questions for Dr. Onyena? Dr. Nosuku?
Thank you. Thank you, Amanda. And Dr. Onyena, that's a very, very good study. It's nice to see numbers and geographical representation as well across Africa on how many studies are there in public domain that actually look at this topic of breast milk and heavy metals or metalloids and how it affects children. So very, very important. Mine is not so much a question, but more a contribution, especially that we've been trying to do similar work here in Zambia, for example. But I think a lot of constraints, a lot of us are constrained. You talked about differences in analytical methods, but it's also the inadequacy of the actual equipment to do this kind of studies. I can tell you that for the Zambian study, I'm sure I know the one that you looked at, it was actually the samples had to be taken to Japan for analysis because we have a project that we're doing with Hokkaido University. We currently have breast milk samples stored in Zambia waiting for some funding so we can take them for analysis for DDT and other POPs. So I don't know if you can sort of comment on the analytical capacity, if you looked at that even in passing within your study of how the continent is doing in terms of the lab capacity, in terms of toxicological training, in terms of the methods. You talked about the methods. We're still developing methods for testing of pulse and breast milk. For example, we don't have accepted methods. We usually just adapt what's already been used elsewhere. So maybe you could just comment on that. And the second part is on the effects of the breast milk. Did any of the studies also talk about, for example, if a child is born first? I think pediatrician will guide me. If it's a prime, if that's a firstborn compared to subsequent children, how does that affect the amount of metals or the concentration of metals in the mother's breast milk? Because literature suggests that first children usually, unfortunately, get the highest burden from their mothers. Did you perhaps have a look at that and how that can influence health education for the mothers as well in those areas? Thank you.
Okay, the first question is analytical method. So it's one of the challenges that we encounter during the research, during the collecting of data. So, you know, when analyzing for heavy metals, you see that there are different standards. So, because there is no established standard, because I mean, when you will want to, some people will want to use the same standard with which they used to analyze their soil sample, maybe a hydrocarbon polluted area. They will still use the same standard. So I do not think there is any established standard for maybe breast milk, or probably some people who may want to also use the standards for that of maybe their food crops. So from the studies, we found out that there are different, even people that are still using the same equipment, AAS, when you check their standards and you check the methodology that was used, they are also different. So there's a need to actually look at way of, seeing that, wow, that these heavy metals have even gone to the breast milk. Then there is a need to maybe have a policy reform and say, okay, let us see how we can get a standard for this. At what level can we say that this is really high? You know, just to establish the particular standard for breast milk, not using it generally for that of food consumption, because that one is direct. Then you asked about, I don't know if that makes sense. And yes, like, okay, you also mentioned that sometimes too, some of the studies, which is also true, like sometimes you might also see the research articles, it's also that those research articles were not conducted from that particular region where the research was done. Some persons may have collected the samples from, let's say, Nigeria, and they took the samples to India to analyze. So those things also can also limit the understanding of, to know how well, in terms of standardization or analytical process, a particular region is doing. So it's also a technology know-how of people, especially in the developing country. So then you talked about education. Yes, actually from the studies we saw, it's from 0 to 2 years. And it's basically from the first time, you know, these things is actually the mother, the pregnant mother, that is actually inhaling, maybe either through dermal contact, through injection, right? So those things are there. So if they actually consume it from their first trial, so they can easily get it, even though they have all those nutrition. But it also calls for a more research on that to know how much. So it should not be a cross-sectional work. That's my recommendation. There should be a longitudinal, so that we see the long term. So that first time, what is the concentration? So they could do the first time, the very first meal that pumps out, how concentrated is heavy metals on that. Then over time too, you might want to also check maybe after 2 months, 3 months. So is it decreasing or increasing? So it's also another area of research that we can also look at, or any other person can look at. Thank you. I don't know if that helps.
Absolutely. Thank you. Thank you, Doc.
Please type your questions in the chat. You can type them directly to Dr. Onyeka, as Dr. Ruben mentioned. Ladies and gentlemen, I'm going to introduce our guest speaker for today, for this morning session, Professor Michael Rudolph. Michael is currently the Director of the Center for Ecological Intelligence in the Faculty of Engineering and Built Environment at the University of Johannesburg. He is also a Director and a Principal Investigator of the Siakana Growth and Development nonprofit organization. Michael has 45 years of experience in teaching, training, and mentoring a cadre of new leaders in dental public health, environmental health, and food and nutrition security in South Africa. He has published widely with several studies influencing strategic interventions and policy in oral health, health promotion, and food security at national, provincial, and local levels. Michael established the Center for Ecological Intelligence at the University of Johannesburg, which has attracted global, national, and a wide community interest. This initiative is now considered a hallmark for integrated programs to promote agroecological in urban, peri-urban, and rural settings through appropriate, innovative, and practical training. Improved food security, greater job creation, economic opportunities, and healthier eco-villages and environments, all addressing the Sustainable Development Goals. Michael received the Vice Chancellor's Academic Citizenship Award at WITS in 2004. Welcome, Professor Michael Rudolph.
Colleagues, I'm going to start the presentation, but before I do so, I just want to congratulate Dr. Les Rubin, Zamina, and everybody for organizing this. It's a great privilege for me to be part of it. I actually was in Atlanta at one of the earlier conferences. It's about 10 or 11 years ago, and it really is a great privilege to be part of this again. So the topic that I'm going to be addressing is a very huge and important topic of food and nutrition insecurity amongst children across Africa. It's a topic that actually requires a couple of days of discussion, and so I just wanted to acknowledge everyone, and just to say that the topic is a very important topic, and I will just highlight some of the issues as we go through in terms of food and nutrition insecurity in Africa, and will highlight some of the work that we are doing in South Africa. This break the cycle has been a very key aspect with multiple books that Les and colleagues have produced, of awards that he's received. And Dr. Les, if I may say so, I'd like to sort of introduce an idea for the future, that it's not only breaking the cycle, but it's building the cycle. And I think that what you are also doing is building relationships, building capacity, and building sustainability. So in addition to breaking the cycle, I would like to suggest that we also build this wonderful cycle and relationship that you've established. I think a number of people have referred to this cycle of environmental health disparities, and quite a number of my colleagues, both at UJ as well as in South Africa, have clearly shown the huge environmental issues that we are dealing with, and manifesting in huge health disparities. So let me just go. Obviously, agriculture is a key aspect of food security in South Africa, and but before I continue, I just want to also acknowledge and thank Dr. Jama Masheli, who is a postdoc research fellow in our center, and Jama has really made a number of very key contributions to this presentation. So in terms of Africa's agricultural footprint, and many of our colleagues are from Africa, they are very familiar with this, that many of the smallholder farmers make up 60% of farmers in sub-Sahara. Just out of interest, in South Africa, we have 2 to 3 million small-scale farmers compared to 35,000 commercial farmers. 23% of the GDP in sub-Saharan Africa comes from agriculture. However, Africa spends $78 billion of currency on imports, which is not ridiculous, but it is so important that we actually, or Africa addresses this. Modern inputs are grossly underutilized, particularly in terms of technology, which is no longer only a nice add-on, but precision agriculture is becoming so important. There's very low investment and ineffective policies. Cool. The market could increase to $1 trillion, and the full agricultural potential is hugely untapped. Climate change, as people have reported in earlier presentations, is a very important aspect which has an impact on food security. So just a couple of key points. So I was saying 78% of Africa's population are unable to afford a healthy diet. The COVID-19 pandemic is far from over, and the ramifications are still very clearly felt today. And I just saw a report that President Biden has got COVID yesterday, and I know quite a number of people that have got COVID. So it's something that we need to be very conscious of. A very important aspect is 157 million people in sub-Saharan Africa are at crisis level food shortages. Often we speak about high level, medium level, or low level food shortages or insecurity, but we're talking about crisis level food shortages and the severe nutritional crisis. And these drivers, as we have heard in the last couple of days, are political. Dr. Rubin mentioned the political environment a number of times, climate change, water and sanitation and health, and I'll come back to that in a moment. So prevalence of undernourishment is high. The next two slides, Zamina, figure 1, just shows the prevalence of undernourishment in Africa by sub-region, and one can see the Central African Republic, Central Africa, Madagascar, we heard a talk, Somalia, Zimbabwe, and Lesotho, and other countries with a very high prevalence of undernourishment. I think it's also important to understand that often the statistics are not always an accurate reflection. These are estimates, and certainly in South Africa, from my own personal experience, I think that what is reflected in this particular study is not quite accurate, but it still is a worrying issue. Malnutrition amongst children in South Africa, and I've highlighted South Africa at 27%, again compared to DRC of 41%, and the Central African Republic at 48%, Somalia at 43%. We really are dealing with a huge crisis if we're talking about our future generations. And all of this malnutrition leads to stunted growth and development. Now, I just want to make some very important points. It's not only physical stunting, it's cognitive stunting, And research has shown that stunting has a direct impact on GDP. So it's not just the Minister of Health that needs to know about these kind of statistics. It's the Department of Education and it's the Department of Economics. And so, as I say, this particular slide and diagram could justify a more detailed a more detailed discussion, but I just wanted to emphasize that the malnutrition leading to stunting is a major problem. And if we want to have our future young children grow up into adults and be entrepreneurs and professional people and teachers and nurses, etc., we have to do something urgently at this point, and certainly this Break the Cycle initiative is doing that. I spoke about climate change earlier, as has other colleagues referred to climate change, and as a result of the climate change and droughts, we're talking about 36.8 million people requiring some kind of humanitarian assistance in terms of food security, nutrition, water and sanitation, and hygiene needs, many of which have been spoken about in earlier presentations today and before. I was also not surprised, but just to show this very recent top global risks, showing extreme weather has been the #1 risk in the world today in 2024. And I'm pleased to say, and I think my colleague Dr. Mashford Zender, also a postdoc research fellow, is focusing a lot on climate change and its impact on small-scale farmers, its impact on food security, and other aspects. So we are putting a lot of time and effort into climate change in terms of our research. The community consequences are enormous, and again, these have also been discussed. Physical and social environments. There have been some excellent presentations, certainly influencing health and well-being of kids. Food security and nutrition, a major impact. Nutritional disparities and change of dietary patterns, not because of choice, but because of poverty. So in South Africa, we are seeing more and more people eating high fats, high sugars, and high salt, just because it's the cheapest food. And this is a typical example of what is happening of people just having white bread, chips, a little bit of meat with questionable hygiene and safety, which has been referred to earlier. This is not only young kids, but at university, we are seeing many students sitting around a very big bowl of chips because they don't have any other way of filling their tummies. This is an example of a range of produce that has been grown in some of the food gardens that we've established. Yes, so I'm just emphasizing the dietary diversity, and that this is food that is grown at the food gardens, at the schools, which goes directly to the kitchens, and in that way enhances the kind of food that is cooked and made for the kids. Food security in South Africa from an agricultural perspective. On the one hand, South Africa is food secure. It produces enough food, but 50% of the population is still food insecure with 20 million people living below the poverty line. I've already mentioned the dualistic agricultural sector with 35,000 commercial farmers and several million small-scale farmers, but with the ratio of supply and production being the 80-20 ratio. So food is available. It's the question of access, utilization, stability, and affordability. I also just wanted to make a brief mention of the informal market. And a recent study in South Africa, in Worcester, in the Cape, showed that the informal market may have been, through quite detailed and modeling analysis, to showing that the informal market could be the most important area for addressing food security in that particular district, which was very interesting, because then this also raises the issue of food hygiene and safety. So the accessibility, the affordability may be better, but it's the hygiene. So we have got a number of community level challenges, low socioeconomic status. The economy is really battling, but we are optimistic with the new government of coalition will help to address that, but that's still going to take time. Unfortunately, poor service delivery and unemployment in South Africa, unfortunately, is one of the highest, if not the highest, in the world. We also have urban food deserts. There's food contamination, which was reported earlier, limited outdoor spaces, and many of these issues have already been addressed. So I'm going to sort of move on. The interventions, we are encouraging household food production, as well as in schools, in villages, but from my experience, this is not a quick fix. This requires a huge amount of planning, of good management, of committed and dedicated people, of appropriate training, and then very importantly of building capacity and ensuring sustainability. So training and support is absolutely essential. We need to we are establishing agri-hubs for employment creation in the agri-center, specifically targeting youth, women, and in some case people with disability. And I was pleased to see in the newspaper with the new Minister of Agriculture, not only at a national level but at a provincial level, of increasing investments in agriculture, in food markets, and general investment. I just wanted to make one point at the bottom of the slide about increasing nutrition education in a study that was carried out at UJ, or is just about to be completed among students, that it shows that students, although they know quite a bit about the importance of nutrition, that doesn't necessarily translate into behavior. So that comes back to the issue of the social and environmental aspects, the affordability, and we are looking at developing games and other digital methodologies to make nutritional education more exciting, more interesting, and hopefully for it to become more integrated. I'm going to just go through some slides about the next slide, please, Amina, in terms of our research, training, and food systems hub at our Center for Ecological Intelligence. And this is just a drone view of our center, which we have established in the inner city of Johannesburg. And for those of you at UJ and or in Johannesburg or the surrounding areas, we would love to host you. We host a lot of people, school children, colleagues from other visitors from other faculties, etc. And we would really welcome you to come. Our mission is to address the high-profile issues of poverty and hunger, including the micronutrient deficiencies, sustainable food systems, job creation, etc. Our focus is on women, youth, and other vulnerable groups in urban, peri-urban, and rural communities. And a key aspect of is our school gardens. I sent Dr. Les some photographs that right now, as I am presenting this talk, there are quite a number of activities acknowledging the Nelson Mandela Day, which is on the 18th of July every year, and I'll come back to that in a minute. Next slide, please. Dr. Les showed the Sustainable Development Goals in his first presentation yesterday morning, and the next slide just shows how we are addressing each of the Sustainable Development Goals at a local level. And I think it's so important not to be over ambitious in terms of no poverty and zero hunger, but to try and reduce these in some tangible ways that can be measurable. So the next two slides show how we are addressing food insecurity. Zamina, we can go now to slide 25, which is emphasizing the training, how one teacher can train, and that doesn't have to be a formal teacher per se at a school. It could be just one of our staff who's got agricultural skills, can train 9 teachers, and then has an impact on 250 students. That is with an average of 25 students per class or something like that. In some of the schools in which we're involved, they have up to 40 children. But the point is that this is a concept that should be further developed. Next slide, please. This is just an image showing some of our courses. Next slide, please, Zamina. This is demonstrating our hub, our aquaponic system of using fish waste to grow vegetables, tomatoes, and this is our produce that we grow: brinjals, peppers, tomatoes, and the green leafy vegetables. This is just an interesting slide showing that we can even grow potatoes in using fish and aquaponics. The next slide, Zamina, 29 and 30, it's a particular a slide that I'm particularly proud of, and this shows our multi and transdisciplinary approach, where we work with the Faculty of Engineering, with the Joburg Business School, with the College of Business and Economics. The next slide, with the Faculty of Arts, etc. I'm jumping to slide 31, Zamina, just showing our growing in our new greenhouse. And as I said, we have lots of school kids who come and see and understand how we grow this produce. Again, I'm conscious of the time. I'm jumping to slide 33, Zamina. This is a particularly interesting slide that we get food from our restaurant and conference center, and we transform that into rich compost. which we use with great effect and efficiency. So this is a very nice concept of the circular economy. We are applying these systems in schools as well, because good, rich compost rather than fossil fuel fertilizers are becoming very important. Now, I wanted to share this slide, is that we are not just growing plants, but we're growing people as well. And Manyasha, Zandeli, and Tanaka all have got a wonderful story of how they are making. So we are building capacity and growing people as well as plants. Next slide, slide 35. Zamina, we have quite a number of work integrated learning students. These are pictures, these are slides of students, agricultural students, who've been allocated to our center to get practical experience. And they are a wonderful group of young people. Next slide. I'm going ahead. Swanee School Program. So very much related to the conference in terms of addressing young school kids. And this is a photograph which is important, which is showing a few of the principals as well as the department, the Gauteng Department of Education and the National Department of Education, who are extremely interested, and we are about to sign a memorandum of understanding with them. The next slide, Zamina, this is again some images of the food grown at the schools, which are benefiting the young kids. I'm going to jump to slide 45, showing a meeting with the Eastern Cape Department of Education. And as a result of our activities with the Eastern Cape Department, they've allocated us 600,000 Rand towards our Eastern Cape schools. The next slide shows the school children involved in the school garden. It's not cheap labor, but making them very conscious of the importance of soil, water, compost, etc. The money which I refer to has gone to a domestic science facility in one of the schools, and this just shows them using the sewing machines. And I'll hopefully next time I'll show you with them doing food preparation. I'm coming to the end, Dr. Les. We've spoken about water and sanitation. This is an actual picture of the toilets at one of the schools in the Eastern Cape. Absolutely disgusting, where over 350 school kids had to use or not use this toilet. And I'm pleased to show the new toilet that we have recently established at our center as a model that we would like to replicate in many areas. It's dignified, it's clean, it's relatively inexpensive, and it is absolutely a key part of our integrated approach. I'm jumping to slide 51, Zamina, and that is that today's talk is an acknowledgement of our former president, Nelson Mandela, whom my wife and I had the privilege of meeting quite a number of years ago. In addition to the incredible resilience, leadership that President Mandela showed, he also this is a picture of him in the Pollsmoor prison, where he loved to have his garden, and he enjoyed spending time growing vegetables in his small plot. He loved planting, cultivating, and harvesting the produce, and he took responsibility for his plot and was the custodian and keeper of his vegetable patch. So in conclusion, ladies and gents, I want to say that all of us today, those of us present, colleagues, mentors and students with whom we work, need to demonstrate our responsibilities and to be custodians of our respective heritages in our different countries, in our different areas. And we need to sow seeds of plants and look after them with the irrigation, the fertilizer, and the loving care, as we need to do with our children. But I also want to make a final statement, is that we need to sow seeds of goodness and kindness. We need to cultivate care and concern for others, because only then can we be assured that we will be planting for the future. Final slide, Zamina, and that is the privilege my wife and I and one of my daughters met with President Mandela. He was already not feeling well, but that was a great privilege. Thank you, Dr. Les. I'm sorry about the delay in getting this going. Thank you, Zamina, for helping for the slides, and God bless everyone.
Thank you so much.
Michael, thank you so much for the, the technical glitches were kind of, we expected some technical hitches. And I must say, so far, this was the biggest one. But thank you so much for sharing with us your experiences, your insights, your ideas, and your exhortations to kind of attend to the world around us in a meaningful, respectful way, and the people around us also in a meaningful and respectful way. So we will move forward, and we will also build the cycle of positivity through breaking the cycle of disparities. Okay, then Orish, and then we'll close for the time. Orish, was your hand up?
Orish?
Yes, just a short question to the professor. Thank you so much for your very lengthy and a very informative lecture. I enjoyed every bit of it. I have a hunch, however. How do you put side by side this message of food insecurity and food scarcity in Africa? Because at the moment, many African countries are battling with food scarcity, nutritional issues, and hunger. And here you are also talking about food insecurity. To the man that is hungry, every food is clean, and anything that is available can be eaten. How do you, balance this food insecurity and food scarcity issues in Nigeria? I mean, in Africa. Thank you.
Thanks for that question. It's not an easy balance. And what I've realized over the years that we have to be practical. We have to use the available resources we have in terms of funding of people. And we have to do the best that we can do in the areas for which we are responsible. So a lot of our work is developing models that can then be replicated. So our work is not to have hundreds or thousands of food gardens in schools, but is rather to set up models, and for the departments of agriculture and education and health, and I mentioned all three of them, and social development, to together in combination help to establish food gardens like this. We're doing the same in villages, which is also aimed at providing a range of produce for the young children. I also just wanted to say that there was a couple of papers that spoke about early childhood development centers. We have got an exciting proposal to start food security and food gardens in early childhood development centers. So it's not only a matter of the safety and hygiene, it's actually getting a range of food products that will boost the immune system, will ensure the growth and development of young kids. So my message is to do the best we can in the environments in which we work, and not to be ambitious, and that hopefully that when people see the successes, and we are definitely seeing more and more interest, not only by government, but by corporates and NGOs in wanting to copy some of the models that we established. Thank you.
Thank you. Thank you.
All right. Thank you, everybody. Thank you, Amanda, for being the moderator of that session and introducing us to the whole world of children's environmental health and all the wonderful work you're doing through the Center of Environmental Health South Africa. The speakers on food safety and security and the metalloids in breast milk. And thank you to Michael Rudolph for this wonderful and inspiring presentation to face the challenges of sort of food insecurity, malnutrition, and all its consequences. Our next presenter will be Mwitwa Magwadi from University of Zambia. So please return in 20 minutes, 25 minutes after the hour. Take a break.
Thank you, Dr. Rubin, and thank you, everyone. Good afternoon. It's a pleasure for me to introduce our next presenter. Her name is Mwitwa Mugode. She is a Master of Public Health in specializing in health promotion and education from the University of Zambia, and currently pursuing another master's, this time in health science implementation and dissemination with the University of Maryland in Baltimore. She has a Bachelor of Education degree in environmental education. And she will talk to us today about the work that she's been doing around lead exposure and environmental health education interventions. So over to you. And I was co-supervising Mwitwa with colleagues from School of Public Health, Dr. Halwindi and Mr. Mulawa. Over to you, Mwitwa. Thank you, Dr. Rubin.
Hi. Are you able to see my screen? Yes.
Yes, we can see your screen.
Okay. So my name is Mwitwa Mugode, and our study sought to explore the adoption of health education interventions for the prevention of lead exposure in Kabwe district of Central Province. Lead is a toxic metal whose exposure accounts for 5.6% of ischemic heart disease, 6.2% of stroke, 3.2% of the global idiopathic developmental intellectual disability, as well as 10.3% of the global burden of hypertensive heart disease. And it accumulates in the body by entering through the mouth. For instance, if vegetables were not washed properly, then that family will ingest that. It also through inhalation, which is breathing in that dust, and splits between the skin. The ones that are the most vulnerable to lead exposure are children that are under 5 due to their hand-to-mouth nature. Most of the time, they tend to pick objects that was in soil and put it in the mouth quickly. That means that they have been exposed, or they are very short, so they will be very close to the ground and keep on breathing in that dust. Some of the effects on the children could be miscarriages from the mother, or a premature birth, low birth weight, and also it results in mental retardation, low IQs, which results into poor performance and in future, poor life earnings, and also sometimes behavior disorders. In 1902 to 1994, the Zambia Consolidated Copper Mine operated in Kabwe district of Central Province. It was mining lead and zinc, and that mine closed without any pollution controls, which now has left 37.5% of the people in Kabwe living in lead contaminated townships. So there have been many interventions that have been done in Kabwe to reduce lead exposure, and one of them was health education, which seeks to improve individuals or communities' knowledge and attitude and behavior towards health. But there are sometimes challenges such as scientific terms during the delivery of the health education, and the community doesn't understand, or miscommunication, or language barriers, or some of the messages don't match the culture of that environment. So despite these interventions, 23% of the children exceeded the 45 micrograms per deciliter, which is above the limit for sedation therapy, and a few others also exceeded 100 micrograms per deciliter, which are all above the CDC limit. Each one should only have a maximum of 5 micrograms per deciliter. So the research question was, have the health education interventions for prevention of lead exposure been adopted in Kabwe town of Central Province? And the objective was to explore the adoption of the health education interventions for the prevention. And because none of the studies that were conducted in Kabwe looked at the health education interventions, so the specific objectives were to first identify those health messages that were given and the sources of information of lead exposure for the residents, as well as to explore the community's perspectives on the effect of lead exposure in Kabwe, and to establish the facilitators and barriers of adoption for the prevention of health education interventions among the community members. The study used a qualitative case study with an exploratory approach. It was done in Kabwe in the hotspot areas, which are Kasanda, Katondo, Choa, Makululu, and Mutoransofu. So the study participants included community members, government officials, as well as non-governmental officials, and purposive sampling was used. Thematic analysis was used to derive meaning from the transcripts, which were generated into codes and integrated into broader themes of the diffusion of innovation theory. For the first objective, which was to identify the health messages and sources of information on lead exposure, the health messages were focused on educating the community members on the extent of pollution in Kabwe. So they would tell them which areas are contaminated so that they are well aware of that, as well as the effects and symptoms. When they notice these symptoms in their children, they should quickly take that child to the clinic, which mostly were observed to be the gastrointestinal tract kind of symptoms such as vomiting and diarrhea, but they could also be headaches as well as anemia. For the preventive messages, the community members were told to, there are many, they were told to sprinkle around the yard as they sweep so that the dust doesn't go in the house, as well as when they're sweeping the house, they also need to mop so that they wipe out the dust on surfaces. They were also told to plant grass in their surroundings, water the lawn as well, so that that grass suppresses the dust, as well as trees. And the sources of information included road shows, and they were mostly facilitated by the NGOs through formal structures such as clinics and schools. They would educate some of the community members from the clinic and some of the children from the schools, as well as IEC material, radio and television programs, and door-to-door sensitizations. For the second objective, which was to explore community perspectives on the effects of lead exposure, the study found that some of the parents indicated that they noticed memory loss from their children. You can send a child something and they just go and bring something else that you didn't send them. Or a 10-year-old is unable to say what their name is. And also some of the children were very vulgar in their language. Then for reproductive implication, they indicated low libido in men. These are not scientifically proven, it was just their observation, as well as a lot of miscarriages. However, some of the community members attributed that to witchcraft. Then for others, they indicated that they don't believe that if they've been exposed to lead today, then they'll ever be exposed again. So they will not follow those health messages, and others just believe that they're immune to lead because they've lived in that area for a very long time. And for the third objective, which was to establish barriers and facilitators for the health education interventions, some of the myths included, for instance, there was a message that children shouldn't be allowed to play in soil because they'll eat it. The community members indicated that they would rather allow that child to play in the soil because they believe that that gives the child vitamins and it also cleans the child's throat. So they can't stop the child from playing in soil. And others believe that if a child is eating soil, that closes the anterior fontanelle, the one that's on top of a child's head when believed to help in breathing. Then traditional beliefs that taught, for instance, to sweep 3 times a day, but then they say that they can't sweep at night, which is mostly when everybody returns from all their workplaces. They can't sweep at night because they feel that that dust that they've stepped on will be used to bewitch them. And also blood superstitions. They believe that the blood that is being taken by the clinic is being used for blood rituals. And when it comes to multiple levels of monitoring, teachers indicated that at school, they're not able to monitor all the children due to the pupil-teacher ratio. They could be 80 teachers against maybe 1,000 children. So they will not be able to watch over those children. And there are also times when teachers can monitor the child from school, but when they go home, that child is not being monitored by the people at home or the parents, and vice versa. Parents may monitor the child at home, but when the child goes to school, the teachers are not monitoring the child. So there will be that kind of exposure. Property restrictions, since they were taught to plant grass, some indicated that they cannot plant the grass because the yard is too small. And also the yard that they live in is rented. So they have to ask the owner to plant grass in the area. So if the owner says no, then they can't do that. Then there were also, some mentioned that the messages were too many to follow and the instructions as well. Then there were also lack of resources. Since they need to plant grass and water that grass, it becomes difficult if they need to go and get water from 1 kilometer away, and they have to pay for it from that side all the way to bring it back to water the grass, because there are times when they have to share who's bathing on which day, because maybe there are 9 in their house. So they can't spend money just to come and pour it on the grass, as well as to afford a diet that could fight the lead in the body, and as well as washing soap for washing their clothes and bedding. And then also healthcare worker attitude. Some of them indicated that they don't follow the messages because a healthcare worker today could be telling you what seems to be sensible according to them, but then tomorrow you see them drunk, insulting other people, so you tend to not take them very seriously. And others just don't have knowledge that they live in a lead contaminated area, so they also haven't heard of any health education messages. So the project breaks the cycle in the sense that the health education will reduce exposure to lead, as well as improve better learning outcomes, which will now result into better life earnings, and it will inform the policy makers and program designers on tailoring health education in the context of Kabwe. The strengths of the study were that the study triangulated, it used focus discussions with community members, as well as in-depth interview with community health workers and key informants from different places such as teachers, counselors, nurses, and NGO representatives. And it also used it got various perspectives from these different categories of individuals. The limitation is that the study findings cannot be generalized outside the context of Kabwe because it was a qualitative study. And the suggestions were that they need to develop, the program designers develop and adapt implementation strategies that are tailored towards the impending factors, which we've discussed, and also conduct a needs assessment and create education interventions that are tailored in that context for the Kabwe residents, or to curb the entire solution from the source, which is to fence the black mountain that is releasing that dust and ensure that the problem is kept away from the source and it won't be recurring. So most of the community members indicated they did not adopt those health messages that they were given, and they would need, the program designers would need to design the interventions in that context. I would like to acknowledge my supervisors, which are Dr. Halwindi, Dr. Mninda, Mr. Mlawa, who were supportive throughout my study, as well as Dr. Lugode and Mr. Francis Matenga, and all the participants from Kabwe district that were very supportive and willing to help me each time I needed anything, as well as thanking the opportunity for Breaking the Circle Africa to present today. And these are my references. Thank you.
Thank you, Mwitwa. That was excellent. And I just have to comment that lead is ubiquitous, been around since the Roman times. And it's still with us today. And when I was a medical student many years ago, we used to accept levels of lead in children that were up to 40, which causes severe brain damage. We now know we cannot accept any level of lead because it does affect brain development, brain function, learning, behavior. And so your work on preventing lead exposure and reducing the likelihood of lead exposure is very, very important. We have 2 questions. In fact, I think we have 3 questions in the chat. Samantha is asking, are there studies which link cultural practices to high lead levels in children? Mitwa?
I didn't get the question.
The question is asked if there are studies that link cultural practices to high blood lead levels in children.
I wouldn't answer that confidently. I haven't researched on that. It was one of my findings that it could be that some of the cultural practices, such as the ones that they said the child could have vitamins when they're playing in soil or eating it, could lead to the high lead levels because they've ingested it. So I would answer that based on my study, but I wouldn't say that I have researched on that.
Thanks, Mitwa. We have Orish raised his hand.
I can just quickly ask my question or my observation. Thank you, Leslie. Mwita Mugode, I hope I'm pronouncing the name well.
Yes.
Yo, thank you so much for your presentation. It's quite illuminating. Just an observation before I make my contribution or I express my concern. Your unit of the blood lead level is supposed to be microgram per DL, but in the slide that you showed milligram per DL. I think you need to correct that. Then my observation is this, not just to you, but to everybody here. And I'm glad that Dr. Rubin is listening. Now, these children that, according to your presentation, that showed as high as 45 microgram per DL, this is quite huge and frightening. It's not different from what we see in Nigeria. That is why I am concerned. My question is this, was this recorded at birth, or was it recorded later on in life amongst the children? If it was recorded at birth, I am thinking that it will be good to monitor these children, and it will also be good to monitor the blood lead level of the mother. There is a need for follow-up of these children up to school age to look at their social behavior, cognitive abilities, and performance in school. This calls for, again, part of what we began to discuss after the conference yesterday amongst the faculty, the need for, collaboration, coming together to compare what we are seeing in different countries by way of putting up some bit of joint proposals and looking for funding. I'm just throwing this open. Maybe Dr. Leslie has something to say, and your supervisors and other people who are into this kind of studies. Thank you very much.
Thank you, Orish. Witwa, do you have any response?
No, the platelet levels were not recorded at birth. They were recorded at the time of the study that was indicated by Yabe and others. For the follow-up, I think I would let Madam Nosiku respond to that one.
I think, Orish, you're asking very good questions that provoke quite extensive discussion. So what I'm going to do is going to say, for those of you who have further questions, please put them in the chat, and then Witwa will get to you directly. And also, please, there's issues on mining, but we're going to hear our next speaker is also going to be talking about lead in mine dumps. And so just in the interest of time, we'll move to the next one. And for those of you who still have questions, please put them in the chat, and Witwa will get into that, answer your questions in the chat. In the meantime, we'll move on to our next speaker, who's Charlotte Mokoatle, who is from the University of Johannesburg. Her mentors, Dr. Nkosi and Professor Mathi, and she's going to be talking about lead-contaminated soil exposure in communities nearby mine dumps and how they remain harmful to children's environmental health. Charlotte, you're next.
Thank you. Good afternoon, ladies and gentlemen. As introduced, my name is Charlotte from the University of Johannesburg, and I am happy to be sharing the presentation titled Lead-Contaminated Soil Exposure in Communities Nearby Mine Dams Remain Harmful to Children's Environmental Health. This is part of my PhD study under the supervision of Dr. Nkosi and Professor Angela Mathi from the South African Medical Research Council. As I go through the slides, you will find it very easy to follow the research perspective of what we have done. But I would like you to allow me to bring some life into the presentation and tell you a little story about a 3-year-old girl that I have named Naledi. I'm a firm believer that the research that we do needs to translate to change in the lives of our people. So I will go through the research, but I want to tell it in a lively story. So this is Naledi's home. This is where Naledi was born, and this is where Naledi spends the 3 years of her life. If you look at behind Naledi's home, you will see a big mine dump and the resemblance of the mine dump on the soil. And this is the soil where Naledi plays every day like any other child at her age. But this soil is likely to be contaminated with pollutants, with heavy metals, such as lead. And we've heard from the previous speaker, we heard yesterday about the damage that lead poisoning does to children under the age of 5 years, children like Naledi. So my big project, or our big project, was actually on evaluating the impact of a personal and domestic hygiene intervention in reducing lead exposure in children in a community close to a mine dump. That was the bigger project. We had 4 objectives, but for the purpose of this presentation, I will focus on the first objective, which was to conduct a baseline assessment of the lead levels in soil. So what did we do? We went into a community called Snake Park, which is in Soweto. Soweto is one of the biggest townships in Johannesburg. It is famous for your Mandela House. It is famous for your Hector Peterson Memorial and many other political accolades. But unfortunately, Soweto is also surrounded by big mine dumps. And similarly, like you have seen, Naledi's home in Snake Park is adjacent to the Durban Roodepoort Deep mine dump. And it is as close as 500 meters to the mine dump. So we went into this area. We went into Naledi's home, obviously after receiving all the ethical approvals from the university, from the SAMRC, and then we entered into Naledi's home. When we entered into Naledi's home, we obtained all the informed consent from her parents to conduct the study. We had a questionnaire with us that we administered, and we also collected soil samples in the yard where Naledi spends most of the time playing. So the 550 you see there is the total number of households that we were able to reach. So the other parts of the study that we did, which I will not focus on here, we also did floor dust wipes. We did hand dust wipes from the children, and we applied an intervention. We went back, we did a follow-up, we did resampling, and then we also checked if the intervention made a difference or not. Hopefully one day I'll have the opportunity to share the other parts of the results. So the data from the questionnaire, we captured it on EpiInfo. We then exported it into Microsoft Excel. We did the quality checks and everything. And then we imported into Stata for descriptive analysis. That was the questionnaire data. And then the soil samples were taken and transported to the lab at the SAMRC Environment and Health Unit, where they were analyzed by a lab technician to determine the lead levels in the soil. So the results showed that definitely there is lead in the soil in Snake Park, meaning that the soil where Naledi plays every day has lead in it. There was no doubt about it. The measurements, even some of them measured up to 60 parts per million of lead in that soil. And then when we were probing the parents with the questionnaire, there are some of the questions that I just extracted for interest linking to the soil and linking to now the concern about the children. So we asked the parents, does the child ever eat soil? And Naledi was one of the 200 children where the parents indicated that they do eat soil. We also asked, have you ever noticed the child putting their fingers into their mouth? And Naledi was one of the 344 children who often put fingers into their mouth. We then asked, does the child ever bite her fingernails? And Naledi was one of the 146 children, which was a yes, they do bite their fingernails. And one may say, this is normal behavior for children. And it's true, it is normal behavior for children. But why is it such a big concern for us? When you look at the questions we're probing now on hand washing behavior, we ask the parents or the guardians, do the children wash their hands before eating? And Naledi was one of the 31 children who never wash their hands before they eat. It was good to see that most children do wash their hands. We were happy about that. But I think Dr. Leslie yesterday mentioned, if we save one child, then we are doing an excellent work. Because 31 children is a lot of children. And then of those that were washing their hands, we also asked, what do they use? And we found that some use water only, and there were those that use water and soap. But our concern is those that do not use water and soap to wash their hands. So if you put the bigger picture together and you consider that Naledi is playing in that soil every day, that is her freedom, that is where she finds most happiness. like any other child, but the soil has lead in it. And then she never washes her hands when she eats. She bites her fingernails, she gets her hands into the mouth, meaning she's getting lead into her mouth, no matter at what level, because the EPA has indicated that there is actually no single threshold that is safe to consider that this amount of lead in soil is safe. There's no such. Even in the blood, the CDC has a reference value of 3.5, but literature has shown that any amount of lead in children is a concern for their development. So when I saw the conference call and I started learning about Break the Cycle, and I took the decision to submit this objective, then I was asked, where do I see my project breaking the cycle? And my response is, the project addresses adverse environmental factors impacting on children's health and well-being, and in their residential home. And a home where it's supposed to be a safe space. But unfortunately for children living in such hazardous environment, that home is not a safe space. So in conclusion, in relation to this specific objective, literature reiterates that soil inlet must be measured and must be mapped to identify priority areas for primary prevention. So this is what we have done with this particular objective, where we've measured the soil so that we can map and identify Snake Park as a community which is a priority area for intervention. And hence, we followed through with now applying our intervention and determining if the intervention was effective or not. And I can share that we did find a reduction in the lead levels post the intervention, just for interest's sake. So the strength of the study, the bigger study, we see a strength where we were able to identify a high-risk area of lead exposure with the recommendation of a simple, affordable domestic hygiene intervention to reduce primary exposure in lead in the household setting, which is supposed to be a safe space for our children. But obviously, like any other study, we also identify some limitations. For example, the parents had to recall some of the responses, so there could be a recall bias, and also the fact that this is a concern for them as well. When we were talking about dust and lead, they were very quick to point to the mine dump. And it's because it's their daily exposure. If you are to be there in a windy day, definitely you will not manage, and they spend their lives there. So they could have given us socially desirable answers in the light of what the study was identifying or addressing. So we identified that as a limitation, we acknowledge it. So suggestions for future, we suggest that more studies should be done, which look at simple, affordable interventions to deal with lead exposure for children in household, in communities, so that research that is done makes a difference in the lives of our people. And it's simple, it's affordable in such a way that we can advocate for it to donors, to funders, even to our government. Hence, the suggestion that we must do research on interventions. And the world agrees with us, because I can also share that I presented the study last year at Lund University in Sweden, and out of the 16 presentations that were there, oral, the study was awarded the best oral presentation. One of the aspects that was highlighted by the panel judges was that the study is interestingly practical and a significant public health issue, which is children's environmental health. Hence, I advocate for more studies that look into interventions to be able to improve the public health of our children. And I think it fits with today's Mandela Day, because we do know that our former president was always advocating for children's health and children's rights. With that, ladies and gentlemen, I would like to acknowledge my supervisors, Dr. Nkosi, Professor Angela Mathi, for their advice and guidance, the entire South African Medical Research Council, Environment and Health Unit. It's a lot of colleagues that have assisted in the project. I saw on the list, Dr. Renee Street is here, and the field workers, the funding I got, the assistance with the laboratory analysis, especially for this objective that I'm presenting here, which is the soil results, and mostly to the parents and the children of Snake Park for allowing me to enter into their homes and for participating in the study. And thanks to BTC Africa for this opportunity, and all the other colleagues from Zambia and the US for giving us the opportunity to really share what we are doing on the ground, which I think we have learned we need to share more. On that note, I will end. Those are the references I've used in the presentation. Thank you, ladies and gentlemen.
Thank you so much, Charlotte. That was excellent. And also a real break the cycle project where you demonstrated a difference with your intervention. And I really like the way you individualized the story by starting off with the little girl, Naledi, and then building the story. I just want to make a comment on mines, and you've got the gold mines in the Johannesburg area, but there was a report some years ago, maybe a decade ago, about children working in mines in northern Nigeria, where they were forced to go in the mines, and they were exposed to very high levels of lead, to the point that there was death of about 400 children, and the lead levels were astronomically high. And it's just a great tragedy. So lead is around, lead is in mines. We need to keep kids away from mines and from mine dumps. Okay, any questions from the audience? Charlotte, you have comments, great presentation, and thank you for informative presentation. Do any of, okay, Samantha, you have a question.
Thanks. I'm not really sure if it's a question as much as a comment, but it's made me think that with all these, with these residential properties that are sitting on lead, let's call it lead infested soil as such, one wonders when we do applications for zoning and for development of residential townships and things, whether we should actually be advocating, or there should be policies in place to ask for the lead levels or the actual environmental status of that soil before we approve something for a residential area and a residential property. I mean, it is difficult with informal areas, but I think with formal properties, it's something that from environmental health side, we should really have a look at before we just approve zoning and such things. So yeah, mine is more a comment because I'm not sure. I know for a fact that it isn't done, and I wonder if it actually isn't something that we can also have a look at as a future study, as to are there any places where they do ask for soil quality studies before they approve for residential areas and schools and nursery schools and so on. Thanks.
Thanks, Dr. Samantha. I agree with you. That would really go a long way. We do have regulations from the National Environmental Management Act that looks at buffer zones. So it directs to say if a new development is coming, you can, up to what point do you have as a buffer zone to make sure that it's developed if it's in an area that is close to a mine dump. But the challenge is with many of these areas that are close to mine dumps are not formally developed. You find in our country, a lot of them is informal settlements that would just mushroom out of nowhere, where people would just rock up overnight, start building structures, and then we have a problem at hand that has to deal with the service delivery, water issues, sanitation, let alone the fact that it's close to a mine dump. So we do have those challenges, but yes, I do take your point. It's something that can really go a long way to assist in this particular issue. Thank you.
Any other questions? Okay, Domiso asked if these presentations will be available. They will be available afterwards. We are recording these sessions, and they will be they become available through our website. There is a question in the chat. Amanda, please ask your question, Amanda. Yeah,
Hi, Dr. Ruben. Oh, thanks. No, it's not a question. I was just interested when Charlotte was talking about future, what needs to be done in the future. She mentioned something like research interventions. And from us as an NPO that we're planning to work with TUT to introduce research interventions in different communities where they're facing different challenges in terms of environmental health hazards that are affecting children. So it's something that is of interest, to look at it, to say maybe we can work with UJ and see how we can, have a formal partnership, apply for funding jointly, so that we establish a center there and we are there full time. We have our volunteers and the people who are doing inspection, but it's something that we have to be strategic, and what is it that we want to achieve at the end of the day. Yeah, that's my comment.
Yeah, no, wonderful.
Thank you.
Orish had the same thought, so I think there's momentum. Thank you so much. That was excellent, Charlotte. So keep up your good work, and we look forward to hearing more at our next annual Break the Cycle of Children's Health Disparities in Africa conference. Our next and final presentation for this conference, student presentation for this conference, is from Angelina Ozor, who's originally from Nigeria but is currently at East Tennessee State University. Her mentor is Mildred Masonet, and she is going to be talking about climate literacy and children's health in Nigeria, integrating climate literacy to address children's environmental health disparities. Angelina, good to see you again, and you're on. By the way, Angelina did present on another topic at our 19th annual Break the Cycle program in Atlanta, Georgia, earlier this year. Angelina.
Good day, everyone. It's a pleasure to be here. My name is Angelina Uzo, and my topic today is on climate literacy and children's health in Nigeria. So this is more like an advocacy project, advocating for the integration of climate literacy to address children's environmental health disparities. My mentor is Dr. Mildred Masonet, and we are from the East Tennessee State University. So what is climate literacy? Climate literacy is an understanding of human influence on the climate and climate influence on humans and society. Changes in our climate affect our environment, it affects our health and well-being, and it also affects socioeconomic development. We've heard a lot today about, and I think yesterday, about climate change and how it's impacting us as a nation and as a continent, and generally just as a world. And how it affects children's health is also unique in the sense that climate change has been studied to cause adverse pregnancy outcomes. It has led to increase in preterm births and birth of low birth weight children. It has led to malnutrition due to food scarcity and food insecurity and water insecurity. It has also caused increase in disease susceptibility of waterborne, airborne, and vector-borne diseases. It has resulted in more missed school days for children, and it has also affected mental health of children. So why is climate literacy important? It has been studied, several studies have shown that education is the single strongest predictor of climate change awareness. With education, you're getting knowledge that also influences your attitude and gives you skills. And with these skills, you're able to make informed and responsible decisions on actions that would affect the climate and also affect our health and development. So education plays a significant role in the comprehension and also in helping understand what we need to do to undertake strategies and adaptation strategies that would affect us. So what's the state of climate literacy in Africa? Based on data from Afrobarometer and from studies done in 33 countries in Africa, the survey showed that 37% of the African population are climate literate. The highest range is 66% in Mauritius and 62% in Uganda, and the lowest is in Mozambique and Tunisia, which are 25% and 23% respectively. Several African countries have taken several initiatives to improve climate literacy, which is a good thing, and more so it's the continent than in others. In East Africa and Southern Africa, countries like Rwanda, Kenya, Uganda, Zimbabwe, Zambia, they have really done a lot in terms of advocating for or integrating climate education or climate change education into the educational curriculums. And generally across the continent, various countries have developed educational programs to improve the education of climate change in their countries. Again, just like we are doing right now, a lot of research is also being done to better understand the impacts, because there's a research gap on the understanding of the impacts of climate change on health and well-being of people, on the health and well-being of children. There's a lot of research gap, and a lot of research is being done in this area to fill up that research gap. Government strategies are also in place, and also a lot of work is being done by non-governmental organizations. The United Nations and its affiliations like UNICEF, UNDP, the World Health Organization, they are partnering with several countries to develop climate change adaptation strategies to help people, farmers, to recover from the impacts of climate change. So quite a lot is being done already. This slide talks about the Children's Climate Risk Index. So the Children's Climate Risk Index, or CCRI, it was made by the UNICEF, and it's a measure of vulnerability to climate stresses. The vulnerability is measured by the country's exposure, sensitivity, and their capacity to adapt to the effects of climate change. So several factors like poverty, that's the economy, governance, and political tension, and widespread conflicts have made it difficult to address the issue of climate change, especially in countries in Sub-Saharan Africa and South Asia. As you can see on this map, a lot of countries in Sub-Saharan Africa are extremely high in terms of the CCI, and countries in Asia are also very high. And there's a paradox in the sense that African countries contribute the least to greenhouse gases emission, but yet they are the ones that are highly vulnerable to the impacts, unlike the countries in the developed world that contribute way more to greenhouse gases that's led to the climate change, but they are better prepared in adaptation to the impacts of climate change. So for this study, I will be focusing on Nigeria. I'll be using Nigeria as a case study. The CCRI, or the Children's Climate Risk Index, is 8.5 in Nigeria. It's making Nigeria rank second worst in the world, alongside with Chad, which is another country that borders Nigeria, and it's located in North and Central Africa. So this means Nigeria is extremely vulnerable to the impacts of climate change. Nigeria happens to be the most populous country in Africa, with a population of about 229 million people. Half of Nigeria's population, that is about 110 million are children. So Nigeria has over one living in Nigeria and are extremely vulnerable to the impacts of climate change. 4 in 10 Nigerians live in poverty. This has affected them in so many ways. Living in poverty, we've mentioned and we've talked about it severally in different presentations today. Poverty has limited access to education, access to basic infrastructure, and also decreased amount of productive jobs for people. So climate change exacerbates poverty, and poverty in itself also exacerbates the impacts of climate change that is being experienced in our countries. Vulnerable of these groups, children, as we've all mentioned today, are the most vulnerable in the group. According to the UNICEF, climate crisis is a child rights crisis. The climate crisis is creating a water crisis, a health crisis, an education crisis, a protection crisis, and a participation crisis for our children. Children do not experience the impact of climate change the same way adults do. Neonates and infants are more likely to die from heat stress and exhaustion than adults because they have immature thermoregulatory response in their bodies. Children are more likely to develop severe diseases and die from vector-borne diseases like malaria that plague the country compared to adults. Children require more food and water per body weight compared to adults. So when they consume contaminated water or food or air, it has a greater impact on their health and well-being than adults. And it's also interesting and important to note that children really contribute the least to the cause of climate change, but yet they bear the greatest burden of the impacts of climate change. So what is the goal? The goal of this study is to advocate for the integration of comprehensive climate literacy into the Nigerian educational system. All right, so for this, I conducted a comprehensive literature review and I analyzed data from surveys to assess the non-perception of climate literacy among Nigerians. The surveys were conducted in 2022 by Afrobarometer, which is a pan-African research network. And the data from the survey were analyzed using SPSS. From this survey, 1,600 Nigerians participated in the survey from all the 36 states across the country and the Federal Capital Territory, 51.9% to a male and 48% to a female. The urban to rural ratio was 57% to 42%. The youngest participants were 18 years and the eldest were 95 years. The most participants were 25 years of age and the median age of participants was 32 years. Participants were asked if they have heard about climate change and only 29.8% said yes, they've heard about climate change. 2.7% says they don't know what climate, they don't know, and 7.5% said no, they've not heard about climate change. Of the 29.8% that have climate change, that is about 477 people, they were asked how climate change are affecting the country, and more than half of them said climate change was making the country worse, either somewhat worse or much worse, but they agreed that climate change was making the country worse. They were asked if citizens can play a role in limiting climate change, and more than half of them do agree that yes, citizens can play a role in limiting climate change. The people that said they knew about climate change were also asked if the government must act now to limit climate change, and over 60% of the people agree that yes, the government must act now in order to limit climate change. Then finally, they were asked who was primarily responsible for limiting climate change, and a great proportion of them, over 75%, said the government is primarily responsible for limiting climate change. Others said citizens, developed countries, businesses and industries, and traditional leaders play a role in limiting climate change. So what this shows us is, in summary, 7 in 10 Nigerians appear to have no knowledge about climate change. But among those that have knowledge about climate change, there seems to be an awareness on the urgency of the climate crisis and the need for climate change adaptation. And this supports why we are advocating for climate literacy and climate education. So what is currently being done in Nigeria in terms of climate literacy? In 2021, the federal government came up with a Climate Change Act that required climate change to be taught at levels of education. There have also been other initiatives to advocate for literacy, climate literacy among youth groups and community groups and grassroots levels. But none of this has really been implemented, which is one of the challenges having. So the recommendations is to develop materials, educational content that is culturally appropriate to the setting and the group, and to integrate the climate change education into the school curricula. Several studies have also been conducted to survey teachers. One particular study that was interesting was one that was conducted by Amachuku, and it showed that many teachers do not even understand what climate change is and climate change adaptation strategies. So we need to train our teachers, and having training programs for the teachers would be very important for them to pass on the knowledge to the students as well. Then community awareness is very important. We don't want to only train those that are in school. We also want to train those that are out of school. We want to educate the adults as well on climate literacy. And we can do this through several mediums, through storytelling, through the use of social media, through the use of science, arts, technology. You know, one study that was conducted showed how talking about climate change on radio stations helped create awareness among local farmers. So when we are able to use culturally or socially appropriate media in telling the story, this would encourage people to take more actions and to encourage the discussion on climate change adaptation strategies among various people. So in conclusion, this study is very important because while children are the most vulnerable and they are disproportionately affected by the climate crisis, they can serve as powerful agents of change. And this is where we break the cycle. How we break the cycle? We break the cycle through, in this diagram, in health outcomes by the climate literacy education. We can break the cycle in terms of poverty, in terms of the health outcomes, and in terms of the confounding factors. So by fostering climate literacy, we can break the cycle of environmental health disparities, and we can create a healthier, more resilient future for our children. Thank you very, very much. I would like to acknowledge my mentor, Dr. Mildred Mercenet, for taking the time to guide me through. My colleague, Jola Tikema, we presented together earlier this year at the Break the Cycle 19th edition for this year. I want to thank Dr. Leslie for nudging me and for giving me the platform to be able to share and contribute my knowledge. I want to thank Ms. Emena. Thank you so much for everything. And I'm very grateful for the Break the Cycle Africa faculty and mentors. Thank you very much for your help and support so far. Yeah, thank you. Yeah, the references I used.
Thank you, Angelina. Excellent, and follows very well on the keynote speakers from yesterday, Carity Wright on climate change and Michael Rudolph's presentation earlier today. So thank you for raising that question. We have time only for one question. Does anyone have a pressing question before we go to a short break and our final keynote by Dr. Margot Brown on climate change as a threat multiplier? So if you have any specific questions for Angelina, please put it in the chat. If not, you can put it in the chat and we'll respond. Angelina will respond later. All right, thank you, Angelina. Actually, before we do break into the for just a short 10-minute break, we're going to ask that everybody switches on your video. We'd like to take a group photo. This will be kind of a screenshot. So if you'd all turn your videos on, and Jimena will take the screenshot. She is our go-to person for everything. And thank you, Jimena. So we'll have a screenshot with everybody. So if you put on your video, Mwitwa, your video, Amanda, Bongani, oh boy, we've got it. Okay. Jimena, you're in charge of all the screenshots, right? Everybody, we've got 6 total screens because we have over 142 attendees at the moment, and we've had over 150 over the last 2 days. All right, Jimena, you let us know when you've taken them, and thank you all for being part of this very exciting program. Stay tuned for our final keynote. And Jimena, let us know when you're all done.
All right. I took a few there, so hopefully I think everyone should be visible. Okay, awesome. Thank you so much.
Thank you, Jimena. Everybody take a 10-minute break. We'll reconvene at exactly 35 minutes after the hour. That's in 9 minutes. And we'll have our final keynote address from Dr. Margot Brown, Senior Vice President of Justice and Equity at the Environmental Defense Fund. And she's going to talk about how climate change is a threat multiplier in Africa. Thank you so much for being with us on this second day of our first annual Break the Cycle of Children's Environmental Health Disparities in Africa conference. And I hope you've enjoyed it as much as I have and learned as much as I have, and found the presentations by the students outstanding and informative and exciting. And also to thank all the keynote speakers today who have been incredibly comprehensive and again also informative, enlightening, stimulating. Our last keynote speaker for the day and for the conference is Dr. Margot Brown, who is the Senior Vice President of Justice and Equity at the Environmental Defense Fund. And she's going to talk about how climate change is a threat multiplier in Africa. And do stay on, because we do have some concluding remarks and give you some opportunities to ask questions as we close out the conference. So Margot, you're on if you want.
Okay, excellent. Greetings, everyone, and thank you, Dr. Rubin, for the kind introduction. I'd like to start by saying a huge congratulations to each of the participants. I commend each of you for developing projects that will break the cycle of children's environmental health disparities and to promote health equity for every child. Today's presentation really centers around how climate change is a threat multiplier in Africa and how it will have detrimental impacts on the health and well-being of its children. As you are aware, and I'm sure you've heard a lot throughout this conference, that children are not little adults, and their health is impacted more directly by climate change. And what we have an abundance of research showing us now is that children today will face 3 times as many climate disasters as their grandparents did. And what's also equally important here is that they've contributed the least to the climate crisis. Their human rights are being threatened, and children's health must be considered in all climate action. The focus of today's presentation is really to understand the inequalities of climate change, how it leads to becoming a threat multiplier, and to briefly examine how a common condition like malaria will be exacerbated by the climate crisis. So just a brief overview of the slides today. The first thing I'm going to do is define the dimensions of justice, then take a little bit of a dive into what the social determinants of health are, explain how climate change is a threat multiplier, look at climate change specifically in Africa, and finally, how malaria is really a perfect example of the interaction between justice, the social determinants of health, threat multiplication, and climate change in Africa. So let's first start by taking a look at the three dimensions of environmental justice. These two dimensions were developed by David Schlossberg. Dr. Schlossberg is the director of the Sydney Environmental Institute and has decades of experience in environmental politics and environmental justice. And what you see here are the three dimensions of environmental justice. The first is distributional justice, and this really aims to provide equal protection and equal access. So it's really important that the environmental costs and benefits are distributed equally across humanity, and we know that that is not the case. The next is procedural justice, and this really relates to the idea of fairness, and that's public inclusivity on decision-making and the equal allocation of resources. And again, we know that that is not the case. The third component is recognitional justice, and this really focuses on the societal structures that reinforce unjust outcomes in a society by acknowledging that some cultural and institutional norms and practices may inherently give unequal representation to certain groups. And all three of these dimensions are very important when helping to contextualize environmental and climate justice. Here you see environmental and climate justice sort of binned in two different areas. What's really important to understand here is that if you go right now to the internet and look up a definition for environmental justice or climate justice, what you're going to see are an array of different definitions with sort of threads throughout them. And so I want to talk about how I define environmental justice and how I'll be defining it throughout this presentation, and the same for climate justice. So I, as Dr. Rubin said, work at the Environmental Defense Fund. And when I think of environmental justice in my work, it's sort of twofold. The first is where we're remedying environmental harms that our organization may have purposefully or incidentally imposed on specific communities. And the other piece is preventing similar injustices from happening in the future. If you look at in the United States, the definition by our Environmental Protection Agency, it's the fair treatment and meaningful involvement. And this gets back to the elements of the three types of justice, because this is really procedural, meaning that it's public inclusivity. So it's the meaningful involvement in all people. And it is really trying to focus on that recognitional part, that acknowledging that there have been some inequalities and we're trying to repair them. And so these definitions, when you think about it, really get to restorative justice. And that's what it means to return disproportionately impacted communities to a place of prosperity and involving all parties. Again, that the procedural piece. And in an international context, this really contains strong historical elements of anti-colonialism. When we look at climate justice, what this really is first and worst. These are the people who are going to be first impacted by climate change. They're going to be the least responsible for the problem. And so What we know is that while climate change impacts us all, the distribution of those impacts is vastly different depending on where you sit in the world. We also know that climate change is a threat multiplier, and it is going to really exacerbate existing inequalities that exist in the world. And the other components of climate justice, as I just said, is that there's an intergenerational and spatial justice component to climate justice, because children today will face 3 times as many climate disasters as their grandparents did. I would be remiss to talk about climate justice without talking about the importance of the social determinants of health. As you all know, the social determinants of health are the conditions in which people are born, where they live, they work, they play, they pray, and age that affect a wide range of health, functioning, and quality of outcomes and risk. And these play a tremendous role in the threat multiplication of climate change. And what happens is there's a cumulative risk that occurs. And so I want you, there's a lot going on in this slide, but we have these determinants of health. And there are a number of factors, depending on where you go, how people will define them. But let's look at early child development. And what we know here is that with climate change, you have existing environmental exposures, and those exposures will be disrupted due to climate change, as will the defense mechanisms that children have in place to address those disruptions. And what's going to happen is it increases their susceptibility to illness and, in some cases, premature mortality, which ultimately leads to a risk for increased health burden and a decreased quality of life. So we know that climate change is a threat multiplier, and it is going to have an unequal impact on historically marginalized communities because it is a threat multiplier. And so it's going to layer upon those public health, economic, and racial inequalities around the world. And it is going to have massive implications for children because their immune systems and organs are still developing, ultimately making them more vulnerable to the threats of climate change. And these threats will be exacerbated due to these existing distributional, procedural, and recognitional injustices. Let's talk about climate change factors with respect to geography and resources. As we all know, climate change is real and it is happening now. This is an image from last fall, where we had record rainstorms in East Africa that caused massive flooding. The impact, like this storm, from climate change is going to have direct and far-reaching consequences on all of us, but it will not affect all of us the same. For people who are living in less wealthy countries around the world, the impact is going to be more severe. In fact, a recent report by the United Nations points to studies that conclude climate change will worsen existing poverty and amplify inequalities, especially those who are disadvantaged by gender, race, class, caste, ingenuity, disability, and age, which means children. So when we think about the geography of climate change, what we know is the closer you are to the equator, the hotter it gets. And in many parts of the world, there's going to be places that are getting dangerously hot, but even more so with people who are closest to those tropical latitudes. And similarly, the closer one lives to a river a lake, and the ocean, the greater the exposure to flooding and potentially diseases that become more prevalent due to climate change. And on top of all of this, we have to think about the different resources available to combat climate change in low and middle income nations. Colonization and post-colonial industrialization play a large role in the disparity of resources. The bottom line is that low and middle income nations don't have as much money to protect their populations against flooding, to provide medical care, and to make sure that they can take care of their people who did not create this climate crisis. Let's take a look a little bit more closely into the link between climate change and one infectious disease. That's malaria that is spread by the mosquito. Climate change in East Africa is causing flooding and increased rainfall, which extends the seasons when mosquitoes are active and expands the regions where they live. Scientists have already recorded a nearly 40% expansion of the range of malaria-carrying mosquitoes in the highlands of East Africa. This expansion is connected to the fact that 96% of the world's malaria deaths in 2019 occurred in Africa. I want you to pause with that statement, and I'm going to repeat it again. 96% of the world's malaria deaths in 2019 occurred in Africa. Nearly every 5 minutes, a child under 5 dies of malaria. And many of these deaths, as we know, are preventable and treatable. In 2022, there were 249 million cases of malaria globally that led to over 600,000 deaths. Of these deaths, 76% were children under the age of 5. And this translates into a daily toll of over 1,000 children under the age of 5. Malaria today is an urgent health priority, and the disease and the cost of its treatment trap families in a cycle of illness, suffering, and poverty. Today, nearly half of the world's population, most who live in sub-Saharan Africa, are at risk for developing malaria and facing its economic challenges. Despite malaria's heavy toll on health and the economy, there have been major inroads made against the disease between 2000 and 2019, and mortality rates with malaria have been cut in half. However, our fight against malaria is very fragile, and it's so closely tied to the climate crisis. In 2022, the total international and domestic funding for malaria control and elimination was $4 billion. However, that amount falls short by nearly half of the approximate $8 billion that are required to stay on track to continue to decrease malaria rates. And with the threat of climate change, the funding for malaria will likely need to be increased to meet the rising cases of malaria in Africa. Of course, while the precise impact of climate change and malaria incidence rates is difficult to predict, we can already begin to see the distinct patterns. And here's what we know. Everyone is going to be affected. However, the low and middle income countries will be more affected and consequently less able to adapt. And the result is going to be the threat multiplication of climate change. Because what we will see is an increasing cycle of poverty and suffering. And this is so precisely why it is imperative that we act now through strategies that are evidence-driven to make the most possible impact. So when I end every one of my presentation, the thing that I like to do is have a call to action. And today's call to action is your presence. It is your work. For all of the participants in today's program, and for all of the individuals who have supported today's participants, by beginning to break the cycle, we can begin to change and improve the health of children who were the least likely individuals to cause our climate crisis. And so I'll leave you with these parting words from Nelson Mandela. There can be no keener revelation of a society's soul than the way it treats its children. Thank you.
Thank you, Margot. That was excellent, wonderful cap to our two-day conference. I'm going to open the floor for questions, and anybody who has any questions, please put them in the chat and we'll pose them to Margot.
Orish,
please, go ahead, Orish.
Okay, so I'll make it very short. Margot, thank you so much for your presentation. Very illuminating and very informative, but at the same time, very frightening. The numbers you mentioned for malaria-related health challenges in Africa is really quite frightening. I live in Africa, and I can tell you that those numbers are likely, if there are 2019 numbers, in 2024, those numbers are going to be even higher. Why do I say that? Because we're having more cases of flooding, houses are getting submerged for days, people are getting seriously displaced, and most of these people are involved in all of these environmental health challenges are children. So my question is, talking about environmental justice, how do you think this book can get help? For instance, we battle with leanness of data in this part of the world, in Africa. I'm not sure these numbers, even as they're being reported, are very exhaustive and very adequate. So what do you say by way of providing a solution to these problems and supplying, making available more data for scientists to look at by way of informed policy makers and escalating the conversation and helping the people that are involved? Thank you.
Thank you. That's an excellent question. There are multiple paths forward to address this issue. I tend to believe that, and this is my personal belief, or so, take this with a grain of salt. There are two paths. One is the political path. With COP, there's an emerging theme around loss and damage. And I think it is imperative that we hold, especially the countries that have done the most to contribute to the climate crisis, that they continue to pay loss and damage funds to the countries in Africa that have done the least to contribute to the climate crisis. And it's not just the payment, but it's also getting politically engaged to make sure that those resources are going to the places in need. That's so much easier said than done. And so how do you begin to shift that balance? One way that I have begun to shift the balance is being incredibly intentional with working with youth across Africa, or I should say across the global South. And when I use the term youth, I'm talking about people who are ages 18 to 35, who are on the cusp of being tomorrow's leader, and educating them around the science and around the policy, and giving them the tools and the resources that they need to advocate for better health outcomes. Again, it's not the easiest answer, but in my opinion, it is the best pathway forward.
Thank you. Thank you.
Okay, thank you, Orish, for the question. Thank you, Margot. Tija Adrian Jan.
Oh, thank you. Hi, Titsa Jemananzara. I really would like to thank you for your presentation today, and all the presenters before you as well. So I really, you mentioned in the environmental justice as well as the climate justice, you mentioned few things that caught my attention, particularly in the historical, context and what has been done in terms of decolonization, the world, because all the things that we're doing in the West are impacting, really greatly the people in Africa, especially. And what are the efforts in terms of, like decolonizing the world? Because basically around that, and then like intergenerationally, because you mentioned the children today, they will face 3 times the effects of climate change than their grandparents. So in terms of educating the world on the effects on that, and basic trauma informed and practices, what are the efforts that has been done? Thank you.
That's a great question. Unfortunately, again, I don't have the most satisfying answer. I don't think nearly enough has been done. And it is one of the things that I grapple with on a daily basis in my job, because the impacts and the ramifications of colonization have lasted for, over 100 years and are continuing to exist today. And I'll give you an example I did not talk about in today's presentation. The vast majority of the Earth's critical minerals sit within a few degrees of the equator. And to get out of the climate crisis that we have created, we're going to need to come back into the places where the Americas and Europe have done, historical and irreparable damage to fix the climate crisis. And as part of that process, to get the minerals out to build solar panels or electric vehicle batteries, there is going to be, in my mind, and we're already seeing it, abhorrent environmental injustices with mining. And that, again, is going to just exacerbate those inequities. So that's a really big picture of doom. But there's a great set of brightness that I see. When anybody asks me in my job what gives me hope, it is the youth. And that's that 18 to 35 demographic. These individuals, especially in the global South, are on fire. And not in a negative way, but they are remarkable. The amount of energy and work that I see that is starting to come to the surface in Africa is remarkable. I am a participant in the Nairobi Summer School for Climate Justice. And this year, that summer school had more than 4,000 applicants for 3 500 spots. And what they've decided to do is make the summer school in person and online. And I really believe that it is the education and the awareness and the advocacy of our youth that are really going to help to move the needle, because I don't think that the people who have caused this problem have the true awareness to get us out of it. And why do I say that? Because I fundamentally believe that the people closest to any problem are closest to the solution. And those young people who are attending the School for Climate Justice, the Summer School for Climate Justice, are the ones who will drive tomorrow's solutions. Is it as quickly as we need it? Absolutely not. But I earnestly believe that it is coming.
Thank you.
We have time for one more question if anybody would like to ask a question. Actually, I'd just like to say, Margot, you're speaking to the very audience that you're trying to reach. We have in our group that demographic who are really have demonstrated over these last 2 days their intellectual kind of capability, their interest, their passion, and the way they can work. So I think you have the right audience. So
absolutely,
yeah.
that's it.
I would just say to this audience, I know this is hard. I know that this can be taxing at times, and I know there are times that you want to give up. But I implore you all not to give up, because the world needs you. The world needs your research, the world needs your advocacy, and the world needs your efforts. And I personally am incredibly grateful for your work, because I'm certain that you will make the world a better place.
for sure. And in fact, Tia, do you want to just say what you wrote in the chat? Because I think let's end with your comment in the chat, if you don't mind.
Yes, yes. Thank you. Yes, I'm in mental health field. I'm originally from Madagascar, and my background include children's mental health, child development, and also social justice and reconciliation. I really believe in neuroplasticity. I'm a mentor, currently also a mentor to young girls in Madagascar, 18 to 25 years old, and there is hope. And the more we learn, the more we come up as a community like this, the more we understand about our past, so not to repeat the same mistake. And that is like knowing our history, knowing what's going on around the world. Yes, we're in crisis, but there is hope. And community, education, and taking care of ourselves, self-care. Those are the big pillars for not only a better present, but also a future, a promising future for ourselves, but also for our children. So yeah, thank you.
Thank you so much. Thank you, Margot, again for agreeing to be our keynote speaker and for presenting us with the realities, but also with the inspiration and the promises to the young people that they will be our future, that they will create and forge a better future for all children. Thank you, Margot. And we could applaud our anyway, thank you. Margot, any final words just before you leave?
No, I would just say thank you to all of the participants, and I would just implore you not to stop, because you are my hope. You are the future. And when I look at the number of participants, it, buoys my soul to see that there is hope, because each of you exist, and the work that you are doing will begin to break the cycle of inequity. So thank you.
Thanks, Margot. And our conference is not over yet, but the formal presentations are. For those of you, please do not leave just yet. We have just some concluding remarks. First of all, a summary by Samantha, what we've experienced the last couple of days, and then some concluding remarks and some kind of thoughts and plans for the future from our three sponsors, Amanda Mbekwana from the Children's Environmental Health Center of South Africa, and Nosiko Munyinda from the School of Public Health in University of Zambia, and myself. So our next speaker will be Samantha Langer, who will do a conference summary.
Afternoon, thank you so much. So during this conference, we've listened to 13 students and 4 wonderful keynote speakers. The topics have ranged from lead exposure and lead blood levels in children. Thanks so much for introducing us to Naledi, Charlotte. That was fantastic. To a wonderful presentation on the Armena program in Madagascar, which trains participants to recognize emotional abuse and its warning signs in youth. Our researchers investigating food safety have highlighted the importance of ensuring safe and hygienic provision of food to children, especially the vulnerable who are reliant on feeding schemes. This was reiterated with our keynote speaker, Dr. Michael Wildelf, who emphasized the importance of food security through sustainable projects such as food gardens in schools, and his projects that he's running look absolutely fantastic. Neglected tropical diseases were highlighted through the presentation by Sunny Boyd and Jiko, showing us the extent of schistosomiasis in children in the Nelspruit area. And one of the studies discussed by Nosiko Munyinda highlighted the use of DDT and its effects on pregnant women and children combating malaria, another tropical disease, and one of the main causes of death in Africa, as we've just heard today. Now, the keynote address by Dr. Nweki introduced us to the equity lens, which should be applied to all policies to ensure that the most vulnerable can benefit from the various policies which have been developed. Our indoor air pollution and child burn safety was researched by Goodson when investigating practices of various cook stove technologies in communities. And this was reiterated in a case study, again by Dr. Munyinda, that's been undertaken by the University of Zambia. Scoping review investigated the link between environmental exposures and undernutrition in children, including exposures as a result of climate change. The literacy levels of Nigerian communities was investigated. Literacy levels of climate change of Nigerian communities was investigated. It was found that 7 out of 10 participants did not have knowledge of climate change and felt that the government should be, a large portion of them felt that the government should be responsible for controlling climate change. Dr. Carity Wright highlighted the effect of increased temperatures on children, causing renal distress and affecting proper breastfeeding due to dehydration. And this is also as a result of climate change. A literature review investigating metalloids in breast milk highlighted how breast milk can almost be seen as a sink for metalloids to be washed through to vulnerable babies. Each one of these wonderful projects highlighted the inequities experienced by children and communities, which was reiterated by Dr. Margot Brown in her keynote address to emphasize that those who were the least responsible for climate change are the ones who are suffering the most. Her call to action is echoed by all the researchers to use their projects to highlight the disparities and inequities and attempt to balance the scale. I urge each one of you, not just the researchers, but everyone who's been at these conferences today, to use the information that you've gathered in this conference and implement it in your daily work as health practitioners. Even if you just use one thing, even if you just take one thing and implement it. As Nelson Mandela said, it always seems impossible until it's done. Thanks.
Thanks, Samantha. Amanda, do you have any closing words and ideas about the future. I think we can take down this slide. Thank you. Oh, that's okay. All righty.
Oh, yes, thank you so much, Dr. Rubun, Dr. Nosibu, Dr. Samantha, and the team, and all presenters and the participants. Wow, I will say a healthier future starts here. Just to conclude, on this vital conference on breaking the cycle of children's environmental disparities, there are 2 points that I just want to make based on the knowledge that was shared, the partnerships that were formed between us and the participants and universities, faculties, the innovative solution presented here to, they offer a roadmap for creating a healthier and more equitable future. So 2 points to say, let us translate this insight into a concrete action that will benefit our children and communities across Africa, not only Africa, even abroad. So the second point, let us continue to prioritize research. We as our keynote speaker spoken about research, let us prioritize on research, advocate for policies that can safeguard children's environments, and collaborate with communities. They are the ones who are going through these things to address the root causes of these disparities, working together so that we can build a world where every child has the opportunity to thrive, regardless of where they are staying, whether in township, informal settlements, urban, rural. Yes, thank you so much, Dr. Ruben. It's an honor, really.
Thank you.
Thank you,
Amanda. I think Nosiko is not here today. This afternoon she had another commitment, so I will conclude. Thank you, Laura Endicott, for your comment. Laura Endicott has been involved in as many meetings as we had planning, and so thank you, Laura. If you could take this down, Jimena, just that, and share my screen. I do want to leave you with thoughts and ideas about our concept of the cycle of health disparities that exist in Africa. And this is not absolutely comprehensive, not absolutely every little detail, but if you do examine this diagram and see how the cycle of elements that contribute to health disparities, to adverse health outcomes, are cumulative. And I think that we identified that in one of the presentations yesterday, and Margot mentioned it again today, is that there's poverty, limited education, limited employment, limited empowerment, limited income. Then you're limited in your infrastructure and where you live. And again, the social determinants of health comes into here, where you live, where you grow, where you learn, where you pray, and where you have friends, where you get your health care, and also all the adverse environmental factors. We heard about lead and other metals, and we heard about other aspects like lack of clean water and adverse social factors that lead to infectious diseases, malaria, diarrheal illnesses, which contribute to significant causes of death, HIV, AIDS, toxins like lead, violence, which we haven't really spoken about, and violence not only individual to individual, which can increase with increased heat, we heard earlier, but also among peoples within countries, among countries between each other, leading to a massive refugee situation. There's over 100 million refugees in the world, many of them from embattled areas, and many of them from crises related to droughts and impacts of climate change and these floods and other natural disasters, and then affecting mental health, physical health, pregnancy outcomes, and perpetuating the cycle. So what I don't mean to have this again as a downer, as a negative, but to say that through the last couple of days, what we've learned is that there's hope, there's inspiration. We've had 13 projects that Samantha just summarized. I'm just going to have a few of them here because they couldn't all fit on this the slide: the lead, the cook stove technologies, food safety, schistosomiasis, lactation, environmental hazards, undernutrition, breaking the cycle of emotional abuse, cognitive stimulation, and importance of climate literacy. So these are the elements that will break the cycle, are breaking the cycle, will continue to break the cycle. And once we break the cycle, we come to the beginning. And this is the first annual Break the Cycle of Children's Environmental Health Disparities in Africa Conference. And I can tell you that there's so many thoughts and ideas going forward around breaking the cycle of climate change, breaking the cycle of food insecurity, breaking the cycle of environmental contamination, and so many cycles to break, and so many cycles to build, so many cycles of strength to build. I do want to leave you with one last thought and idea, and say that the future of the children of tomorrow is in our hands, and as Margot Brown said, in the hands of those of you who she categorizes as youth, and that you need to remember that even though you may not make that big change and complete the task, you're not permitted to desist from undertaking the challenge, which means keep doing what you're doing, keep exploring, keep learning, keep trying to make a difference. And as Michael Rudolph said, you don't need to feed the whole world, and you just feed one child. That child will grow, and that child will save the world. He had this wonderful diagram where one teacher inspires number of teachers, and each of the number of teachers inspires the students, and the next thing you know, you've got hundreds of students who are inspired and learn. So we just need to go on and continue to promote the message that we can all make a difference in the world, and that it starts here. And I wish you all good health, you and your families good health, and inspiration and energy and drive to make a difference in the world, break the cycle of children's health disparities, promote greater collaboration and relationships, because together we can do so much more than each one of us can do alone. Thank you all for being here. And I just say, keep up the good work.
Thank you, Leslie.
Adios. Sayonara.
Thank you.
Thank you.
Bye-bye.
Thank you so much.